So welcome to Health and Human Services. Before we start, I know you were with us last week. Why don't you introduce yourself to us? Sorry to put you on the spot.
Hi, I'm Jessica Sternberg. I'm a grad student at UNH studying public policy, and this is my second week here at the Senate interning for you guys, and I'm very excited to be here.
Welcome. We're glad to have you here. Okay, with that, we will start with Senate Bill 350 and invite the prime sponsor, Senator Susie.
Thank you very much, Madam Chair, members of the committee. For the record, I'm Donna Susie, representing Senate District 18, and I'm happy to be here with all of you this morning to introduce Senate Bill 350. Just to provide a little bit of context, because I know the committee recently has heard a number of different bills dealing with health issues related to the profession of firefighting. And as many of you know, this legislature has endeavored to spend a lot of time studying and gathering information from experts about the types of health conditions that can occur as a result of employment. Previously, those studies resulted in some changes to our workers' compensation statute, primarily changing the presumption of who gets these types of illnesses and how they are contracted, which is through the profession. So what this legislature in its wisdom previously did was to shift the burden of proof in these cases so that instead of the individual who is found to be ill, the employer has to prove that someone didn't in fact get this illness through the profession. So that's already settled. That's the process as it works now. What this bill does, and actually it's one of those cases where the analysis pretty much says it, but what the bill does is say that in addition to the presumption, it mandates that employers or their insurance carriers maintain the health insurance for the affected worker at the value of a single employee premium until a determination is made, including any appeals. The issue that we're trying to address, and I won't get into a lot of specific examples, there are some folks behind me that will testify as to some claims that have already been heard. The issue is to ensure a continuation in coverage so that someone who's identified with an illness maintains insurance, because otherwise there have been instances where there are gaps in the treatment, and we all know that those situations where someone has already been diagnosed, if they don't have the ability to maintain that coverage, it means that that might limit their ability to pay for that treatment or that coverage out of pocket. So all we are trying to do here today with this legislation is ensure that people continue to have coverage. And there are limitations, obviously. I also, for your edification, need to point out that there is one drafting error in the bill. I would strongly encourage you to support it. I did not have the opportunity to have an amendment drafted, but it's a very simple issue. If you go to line 6 of the bill, where it says prima facie presumption, you would need to strike out under RSA 281-A:17-C. So it would now read prima facie presumption applies. The reason for that is that we have more than one prima facie presumption. This language is limiting, and there may be more in the future. So to the extent that somebody is working through the statute, we want to make sure that this language would apply to all the instances where the presumption exists. With that, I will conclude my testimony. As always, I appreciate questions from my colleagues, but as I said before, we do have an attorney who is a practitioner in workers' compensation who will be testifying, as well as a couple of our firefighters who can talk to you a little bit more about specific examples where this has occurred. So I think it would be best if you have more technical questions to defer to them, but I leave that to the indulgence of the committee. Thank you, Madam Chair.
Thank you, Senator. Any questions from the committee? Seeing none? Thank you. Brian, welcome. Long time no see.
I promise I won't be in here all year. Morning, Madam Chair, members of the committee. My name for the record is Brian Rill, the president of the Professional Firefighters of New Hampshire. I come before you this morning in support, obviously, of Senate Bill 350 and would thank Senator Susi for bringing this bill forward. I'm going to be very brief in my testimony today, unlike last week, as I think we have some compelling testimony to follow. But we are very supportive of this legislation. And just for a little context, what we've been finding with some of these presumptive cases is that there is a quick, early denial in some of these claims. While a member is working through the appeals process, which could take up to 18 months, if they exhaust their vacation leave or earned time or disability leave, which can happen in the case of a young firefighter, they are left without the potential, in some cases, to have health insurance coverage. The reason for that is with minimal job security laws here in New Hampshire, a member can be released with the exhaustion of their leave, with the exception of the fact that they may be reinstated if they get a clear bill of health from their doctor. What we're trying to do here is just bridge that gap while the appeals process plays out, which can be for either minor technical reasons or a long-term appeal that involves subject matter experts testifying as to the validity of a claim or other circumstances. So what this does is it assures that while one of our members are potentially fighting for their health or their lives, they're not having to worry about the added financial burden during this process. So they would continue to pay their premiums as normal, and the employer would continue to pay the premium as normal until this appeals process plays out. One thing I would highlight in the methodology is that the Department of Labor has looked at this, and while there's no fiscal note, to my knowledge, yet on it, they expect that the costs on this would be minimal to state, counties, and local jurisdictions. So I think it's a win for all. So I would ask for your support and happy to answer any questions.
Any questions from the committee? I only have one.
Sure.
So, working on the PTSD commission, the one thing that I did learn is a lot of these cases going for appeal, or many of them are just because the medical information has not been compiled to get to the workers' comp. So it's usually brief, not too long of a period before that medical information gets back to workers' comp, and then they present the appeal.
Correct.
Correct?
Yes. Yeah, I believe that's correct. And I would also add that, to my knowledge, this is by and large the exception, not the rule. I think that in most cases, employers, I'll say it, even though it's left to interpretation, employers do the right thing, and they look out for their employees, and they want to keep them on so that they can continue to have the healthcare for as long as possible. There's also things like family medical leave. There's internal disability banks within departments that can offer some support as well. So again, I think this is the exception, not the rule.
Thank you. Any other questions? Seeing none? Thank you, Brian.
Thank you.
Jared O'Connor? Truly long time no see.
Indeed. Good morning, everyone. Good morning. So my name is Jared O'Connor. I'm a workers' compensation attorney. I represent claimants at the Labor Department. It's the sole focus of my practice and has been for about 20 years. and I, in recent years in particular, have been representing firefighters and other first responders in many of the kinds of claims that this legislation addresses. So I'm here in support. And I really wanted to just talk about some of the procedural aspects of why this is necessary and to answer any questions you may have about what this looks like on the ground in practice. And so essentially what happens in many of these cases, the majority of cases, I would say, where a presumption applies.
Could we not block the doorway? You can line up over here. Go ahead, Sharon, sorry.
Thanks, and that's okay. So I would say the majority of cases in which a presumption applies, the carrier or the employer will review the case, accept it, and pay, and that's the end of the story. This addresses when a situation arises when there is a denial. And it certainly is true, as was previously indicated, that what can happen in some instances is someone will be diagnosed with a condition to which a presumption applies. So PTSD, cancer, lung disease, heart disease. They file the workers' comp claim. Because the law already requires a response from the carrier or the self-insured employer within 21 days, that's not a lot of time to gather the medical records and make a determination. And the carrier understandably doesn't want to just blindly accept the case without looking at the medical records to assure that this is what's appropriate. So they issue that initial denial. The employee at that point has the rights and the obligation to request a hearing at the Labor Department. It's certainly true that then medical records can be gathered, and then after a month or 2 or 3, the carrier can revisit and accept, and the case is accepted. It's over. No further litigation is necessary. Great. This addresses what happens if the denial is maintained. So if the insurance carrier or the employer says or has reason to believe that this may in fact be non-work related, and so they issue the denial, then the employee requests a hearing at the Labor Department, goes to the department, has a hearing, gets an initial determination. That initial process maybe takes 4 months, maybe 5 months, depending on the complexity of the case. When you get that initial determination from the Labor Department, if it's favorable, so the claimant wins in this respect, and you have an order that says, yes, this is in fact a work-related condition, what they get at that first level is weekly indemnity benefits payable, but medical is not yet payable, even with a win, if the carrier appeals. So the medical isn't ordered paid until the case is over at the appeals board level, which can take another 6 to 8 months, depending on, again, the complexity of the case. And so what this legislation does is require the employer to maintain the employee's health insurance so they can continue to get the treatment that they need while the case is being litigated. Because again, even if they win the hearing, their medical is not being paid by the carrier, the workers' comp carrier. It's being paid by their health insurance carrier because the comp case hasn't yet been resolved. So when you get to the end of the case, you've had your initial decision, you've had your appellate decision, that is a final decision. Now we have an answer. Is this occupationally related or isn't it? If the answer is it is in fact occupationally related, then the comp carrier will step in and reimburse the health insurance carrier for everything it's paid to date. If at the end of the day, the answer is no, you failed to meet your burden, this is not an occupationally related condition, then the health insurance carrier should have been paying the whole time in any event because it's not work related. So one or another carrier is going to pay. The question is, which is it?
Senator Avon.
Thank you. So if it's not work related and the employer is on the hook for the premiums, when is the employer off the hook for paying the premiums?
Under this legislation, they're off the hook when you get the adverse decision. So when you get the final decision from the appeals board that says this is no longer related, the case is over, this obligation also terminates. It says, and then you can see this in paragraph Roman 1, where it says they maintain the benefit until such time that the commissioner, the Labor Department, makes a final determination, including any appeal.
Senator Broadley.
Good morning. Thank you very much. So there's a relatively small universe of these folks that are affected just by terms of employment status. So primarily group 2 members in New Hampshire. There are maybe 3,000, 3,500. In your best estimate of that universe, how many individuals are impacted by this on an annual basis?
Well, I have two things to say, actually. One is it's not limited to just Group 2 members. Just to be clear, if you look at the initial language, it's emergency response public safety workers.
I get that,
Okay,
but it's primarily.
yeah, of course, yes. All right. So just to be fair, in terms of how many actual individuals are affected, it's hard to know from my perspective. I mean, as someone who does this and this exclusively, I would say I probably personally have 5 to 6 active clients this year.
Okay,
That's just me.
Okay.
But I would say so fairly small universe
Yeah.
is what we're talking
all
about.
right, thank you.
Any other questions from the committee? Seeing none. Thank
Okay.
you, Jeremy.
Thank you.
Jeremy LaPlante. Welcome.
Good morning, Madam Chair and members of the committee. For the record, my name is Jeremy LaPlante, and I'm a lieutenant with the Keene Fire Department, having served my community for the last 15 years. I stand before you today to strongly advocate for Senate Bill 350, which seeks to bridge a critical gap in health insurance coverage for emergency response and public safety workers facing a prima facie or presumptive conditions. Every day, firefighters across our state put their lives on the line to protect our communities. Recognizing the inherent risks, New Hampshire law provides a prima facie or presumptive coverage for us. However, there remains a significant gap. Excuse me. Currently, if a firefighter is undergoing medical treatment, then loses their job due to the injury or illness, and their workers' compensation claim was denied, they face a precarious situation, lacking health insurance during a critical time. As a veteran firefighter, I have used my sick leave for various reasons, including COVID-19, work-related injuries to my foot and shoulder, and family emergencies, specifically the premature birth of my son. I currently have about 12 weeks of sick leave accrued. But what happens if I, or any firefighter, face a serious health issue and our compensation claim is denied? This is not a hypothetical situation. It's a reality we live with every day. We are then forced to exhaust our sick and vacation leave. And once that's depleted, the Family Medical Leave Act, or FMLA, only protects our employment for 12 weeks. After that, we're left without income and, critically, without health insurance. What does this difference in coverage look like for a family? Yesterday, I spoke with a colleague who was just diagnosed with stage 4 prostate cancer. One medication needed for 1 month to treat his cancer is $13,000. Luckily, with his health insurance, he's only responsible for the $40 copay. Consider some other potential but very realistic scenarios. A newly hired Concord firefighter and paramedic on their first day responds to an active shooter incident. The trauma experienced, physical, emotional, psychological, is immense. It may take time to rehabilitate after such an event. If this firefighter's compensation claim is denied, they face not just a daunting recovery, but also the loss of health insurance, with no accrued sick or vacation leave to fall back on. Similarly, a few years ago, a Manchester firefighter suffered a cardiac arrest while fighting a fire. Situations like these underscore the unpredictability and immediacy of the risks we face. Senate Bill 350 directly addresses these situations. It ensures that while workers' compensation claim is under appeal for a presumptive injury, the affected emergency responder retains their single-person healthcare coverage. This bill isn't about sustained income. It's about ensuring that during the most vulnerable times, our firefighters aren't burdened with the added stress of how to pay for their immediate medical treatments. No firefighter should face the haunting uncertainty of standing at the brink of unemployment with their sole option being to pay out of pocket for their next mental health session, cardiac rehabilitation, or cancer treatment, all while their workers' compensation claim for a presumptive condition is pending appeal. In conclusion, I urge you, esteemed members of the committee, to support Senate Bill 350. This bill is not just a piece of legislation, it is a safety net for those who dedicate their lives to serving and protecting their communities. I cannot stress enough the peace of mind and security this bill will provide to our emergency responders. Thank you for your time and consideration, and I'm happy to answer any questions you may have.
Thank you. Any questions from the committee? Seeing none. Thank you. Jeremy was our last speaker. Is there anyone here that would like to speak that wasn't given the opportunity? With that, I'll close the hearing on Senate Bill 350 and,
I'll move executive session.
okay, move executive session. Senator Avard seconds. All those in favor say aye. Aye. I know. He moved ought to pass.
I'll second it.
Okay. Senator Bradley moves ought to pass. Any discussion?
Oh, I'm sorry. We need to do the amendment.
That's right. I was just looking at that too.
All right, I'll move the amendment, that strikes the language.
So the amendment needs to be,
Strikes out RSA 281-A colon
Right.
17-C and just leaves under presumption under applies colon.
prima facie presumption applies.
Yeah.
You have to remove under as well, so it has to say prima facie presumption applies, period.
Okay. Got that? And
I'll
that-
second that.
All those in favor of the committee amendment say aye.
Aye.
Opposed? Okay.
So I'll move on to pass at this point, and if I could speak to it, I think, based on the testimony, if there was gonna be a significant cost, we've heard from the Labor Department, heard from the Insurance Department, heard from the Municipal Association, heard from the Association of Counties. I think the testimony, especially from this gentleman, next to Senator Susie, that it's a handful of people.
Jared.
There is no question that we should probably move forward with this.
Okay. Senator Bradley moves ought to pass as amended. Senator Avard seconds it. All those in favor say aye.
Aye.
Opposed?
I'll move consent.
Second.
All those in favor of consent say aye.
Aye.
I will take it out. Okay. All right. We'll give Cam a few minutes to set up and me. And
Yeah, no, you should have.
So I
Thank you, Mr. Chair. Thank you, committee, for hearing Senate Bill 353, which I am a co-sponsor, and Senator Waters apologizes he couldn't be here today. This bill basically clarifies insurance coverage for autism spectrum disorder and Down syndrome that is pursuant to RSA 417-E. And I'm sure there are many people behind me that would like to speak on this bill.
Questions of Senator Birdsall? Seeing none. Thank you.
All right. Good morning, and thank you for allowing me this opportunity. My name is Caitlin Copeland, and I provide services for individuals with developmental delays in the greater Nashua area. I'm asking for support on SB 353 to broaden insurance coverage for applied behavior analysis to include people with Down syndrome. I'd like to share my experience as a board-certified behavior analyst and highlight some trends I've noticed during my years of clinical practice. Applied behavior analysis, ABA, is a proven treatment method for individuals with autism, Down syndrome, and developmental delays. This therapy focuses on teaching communication, social play, and daily living skills while reducing challenging behaviors. Both individuals with Down syndrome and autism share similar developmental challenges such as communication, socialization, and daily living skills, as well as occasional behavioral difficulties. ABA therapy is typically delivered in various settings, including homes, schools, communities, and centers. It begins with a BCBA conducting an individual assessment to identify the person's needs and strengths, collaborating closely with the school team and caregivers. Based on this assessment, the BCBA will develop tailored programs and supervises a registered behavior technician, an RBT, who will work closely with the individual. RBTs provide one-on-one support, breaking down complex tasks into smaller steps and using positive reinforcement to encourage progress. For instance, if an individual struggles with verbal communication, the RBT may model the desired word and reinforce any attempt to mimic it. ABA also uses prompts to guide individuals towards the correct behavior, gradually fading these prompts as the person becomes more independent. Progress is carefully tracked using data systems, allowing for adjustments in the therapy plan as needed. Each ABA program is customized to meet the specific needs of that individual. Currently in New Hampshire, ABA therapy is covered by Medicaid for individuals with autism, but not those with Down syndrome. This means that children with Down syndrome may not receive ABA therapy until they enter a school district that offers it, potentially missing out on crucial early intervention. Some families have even sought an additional diagnosis of autism for their children with Down syndrome to access ABA therapy. Senate Bill 353 aims to address this disparity by ensuring that individuals with Down syndrome and their families have access to an evidence-based therapy, irrespective of any controversy surrounding ABA. The goal of SB 353 is not to debate the merits of ABA, but to ensure that individuals with Down syndrome receive the support they need through a proven therapeutic approach. Thank you, members of the Senate Health and Human Services Committee, for considering this testimony, and I urge you to support Senate Bill 353 to help numerous families across New Hampshire.
Thank you. Any questions from the Senator?
Thank
Woodley?
you, Madam Chair, and thanks for taking my question. I'm not sure who the right person to ask is, but I see as part of the bill, in addition to adding Down syndrome, we're changing language from pervasive developmental disorder or autism to autism spectrum disorder. Is that just an update to the term?
It's an update from the diagnostic manual.
Okay.
5, that the PDD no longer exists as a diagnosis.
Got it. So, follow-up?
Follow up?
So PDD used to be the diagnosis for autism spectrum disorder. Okay, follow up. So because I was just wondering whether I didn't want to exclude other developmental disabilities.
Yeah, so PDD now falls under the umbrella term for autism. They with the DSM-5, they got rid of PDD, and along with Asperger's, it all falls under the same category of autism.
Okay, last question. Are there any other developmental disorders that do require disabilities that do require ABA
I think
or would benefit from ABA?
yes, Yes. Um, ABA has been proven evidence-based for any individual with developmental disability as required by for insurance coverage. We need a medical doctor to sign off and say that this treatment is necessary. There are numerous diagnoses, including genetic disabilities, that I know families that have these individuals with these disorders that are not able to get ABA therapy even when a medical provider has signed off for ABA for insurance-based coverage. So yes, I think that honestly, it is still excluding a population. I don't know currently the correct verbiage to use in order to broaden that to all developmental delays.
Last question. And I asked this, it's a personal issue for me. My sister-in-law does have a developmental disability. It's similar to Down's, but it's a different chromosome. And so I just want to make sure that we're inclusive. And so would you be open to perhaps being more inclusive than just Down?
I would love that. Honestly, I would love it. And when first speaking about this and looking at trends of other states, including Down syndrome is the first step. It's not the end step. It's one step closer. Expanding the coverage across all developmental delays with clinical background or clinical recommendations, including medical recommendations, would be the way I would love to see the future of this bill.
Thank you very much.
Any other questions from the committee? Seeing none. Thank you.
Thank you.
Will Walker? Welcome.
Good morning. Thank you, Chairman Bertel and members of the House. Health and Human Services Committee. Appreciate the time to speak today. My name is Will Walker. I live in Hollis, New Hampshire with my wife and a 24-year-old son with autism. I am also a legislative liaison for Gateways Community Services out of Nashua. I have a list of about 275 people that I lead and help represent them here in Concord. I'm going to read testimony that was handed to me this morning by somebody that was unable to drive here because of the snowstorm. But I also, from my personal experience, my 24-year-old son with autism received ABA when he was young, and ABA covers all sorts of areas, all sorts of aspects of helping people. For my son, it helped him with communication. Okay, so we took a son that we were unable to communicate with, and through ABA, it really improved and opened up the door to talking with him. But I'm going to read Carrie's testimony today. So if you hear me say I, I'm speaking on behalf of Carrie Duran. My name is Carrie Duran, and I live in Wolfboro, New Hampshire. I'm asking you to support SB 353, as am I, Will Walker, to broaden insurance coverage for applied behavior analysis, ABA, to include people with Down syndrome. My daughter Katie, who was born with Down syndrome, is a vivacious, loving 12-year-old. Her love of life and love of people, coupled with her diagnosis, can often cause behavioral challenges that are difficult to moderate in a school environment and in public settings. Katie will often become overwhelmed with social situations with her peers or loud noises, which leads to poor personal safety decisions such as running out of the classroom or the school building. Her love of people and need for social connection again leads to safety concerns when out in public, when she can't help but hug everyone, particularly complete strangers. These behaviors are but one example of Katie's behavioral challenges. Thankfully, we have support within the school district and are developing comprehensive safety plans and behavior plans. My concern today, and why I support SB 353, is for when Katie is an adult, will she have access to ABA? Will she have access to the behavioral support to navigate her community and to stay safe? Applied behavioral analysis will be the tool she will need to live her best life, and it should be available for all to access regardless of what kind of insurance they have. ABA therapy needs to be accessible to all who need it to be successful and to thrive. Thank you, Chairman Birdsall and members of the Senate Health and Human Services Committee for considering my testimony. I urge you to support SB 353 to help Katie and so many others to obtain insurance coverage for ABA. This will help my daughter Katie to live a full, inclusive, and productive life. And I'll augment Carrie's saying, yes, I also urge you to please support SB 353 to see the impact that it had on my son with autism.
Thank you, Will. Any questions from the committee? Seeing none.
Thank you for the time today.
Megan Foster? Excuse me.
Hi, I'd like to thank the chair and the committee for the opportunity to speak. My name is Megan Foster. I live in Dover, New Hampshire. I'm a nurse there. I am a Lend graduate, and most importantly, I am mom to, Xander, a 6-year-old boy with Down syndrome. I'm asking you to support SB 353 to broaden insurance coverage for applied behavioral analysis, or ABA, to include people with Down syndrome. Like I said, I'm mom to Xander, a 6-year-old boy with Down syndrome. And last summer, we had the scare of our lives. Oh, shoot. I practiced so many times.
That's okay. Take your time.
When Xander eloped from a summer camp that he was at, he was gone for about an hour in an area surrounded by water. Later that month, he also swallowed a number of, this is my husband, acetaminophen tablets and had to be treated in the hospital. We started researching behavioral interventions, and during that research came across evidence regarding the effectiveness of ABA with individuals with Down syndrome. We had a ton of assessments done, including evaluating him for autism in order to have access to ABA. The providers who knew Xander best decided that the interventions offered by ABA were medically necessary. I've included in the testimony I handed to you recommendations from both Boston Children's Hospital and the director of the Down Syndrome Clinic at MGH, Dr. Scott Go, who knows Xander very well. As a registered nurse myself, utilizing evidence-based tools is incredibly important. ABA could address not only the major safety concerns that we had for Xander, but also help him with the personal hygiene and self-help skills that would protect Xander's personhood, dignity, and health for the future. When applying for coverage for ABA, the assessment by our insurance, it took over 8 months to process because Xander didn't have an autism diagnosis. After the assessment showed that he would qualify and benefit from ABA, we began services. And we heard that our insurance again denied coverage for the services due to him not having an autism diagnosis. Despite the research I presented them, the medical necessity is deemed by 2 reputable doctors and documented progress that these services had been effective almost immediately. These things didn't matter to the insurance company because Xander didn't have a diagnosis of autism. Xander has continued ABA therapy. He's been in it about 8 months now and has made strides in participating in safe and health-promoting behaviors. Thank you. That will serve as prevention for major health problems later in life. Specifically, he's gone from wearing a CPAP mask, so he has obstructive sleep apnea, and doesn't tolerate the CPAP mask, or didn't. He went from 17 seconds to 5 minutes in the last 6 months. He's had no episodes of eloping, and he's been able to tolerate toothbrushing. He's had moderate success with toileting, which wasn't something that we ever thought he'd be able to do. We also have hope that he will be able to wear glasses, which he needs, and a hearing aid, which he needs. As a nurse, I look at this list of skills and think about all the ways that this will save him from future medical needs. My husband, Xander's dad, said that he is most grateful for the ways that he's seen Xander be more successful in interacting with his peer group, accessing his education, and as a mother, I'm grateful for the ways that this has created systems in our home that help us navigate caring for Xander in ways that preserve his personhood, his dignity, and his health. Thank you, Chairman Birdsell, and the members of the Senate Health and Human Services Committee for considering my testimony. I urge you to support this bill, SB 353, to help Xander obtain insurance coverage through ABA, for ABA. This will help Xander live a full, inclusive, and productive life.
Thank you, and good luck. Any questions from the committee? Seeing none, thank you.
Thank you.
And thank you for coming in.
Yeah.
Alex Foster. Oh.
thank you so much for being here today and hearing about this. You heard, I'm Alex Foster. I live in Dover, proud UNH graduate, and I work at Liberty Mutual. And on that day when Xander was left, I was at our Portsmouth office and got the call that he was missing. And I was speeding down the highway, trying to think, like, what more could we have done? We had worked with the camp. We had read every behavioral book to put every safeguard in place, but it wasn't enough. And as a parent, feeling weak and not able to care for our child is very hard. And so we got him seen by many professionals, all suggesting ABA would be beneficial for Xander. And then to see him denied, not because it's not medically necessary or he would benefit from this, but because he didn't have a certain diagnosis, was very hard. We have been very fortunate to get ABA for him, and for me to see him be able to build friendships with his peer group, to see him be able to access his education in a way he wasn't able to before, is so encouraging that this investment in him is really going to cause a lifetime of being a valuable member of our society, being able to have a job, possibly live independently. And so I ask for support for this bill for other individuals who need this help, who will give them a better life and their family a better life. So thank you so much for your time and consideration of this bill.
Any questions from the committee? I do have, and I meant to ask your wife too. Was he given the treatment? Was he denied before he got diagnosed, or did they diagnose it and they still took a while, denied it for a while?
So Xander's had a Down syndrome diagnosis since he was born. He does not have an autism diagnosis. We sought out an autism diagnosis and everybody said there's no way this child has autism, but he will benefit from ABA therapy. So we went to multiple clinics in search of as much medical support as we could to recommend ABA to combat the denial with the insurance company. He has continued to receive services because I contacted every senator upon his denial, and Senator Whitley, you were one of them that I emailed, and Senator Waters as well. And I don't know if he's going to continue to receive those services. Our insurance company has apparently bent to the input from the senators that we talked with, but our reauthorization is due in 2 days, and we don't know if he will be able to continue with these services.
Okay, so originally the bill was basically covered autism or pervasive we're adding Down syndrome.
Yes.
Okay, just want to clarify. Thank you.
Yeah.
Any other questions? Thank you. Andrew Hosmer. Andrew, before you start, can we not block the doorway? And you can stand over here.
Good morning,
Morning.
Chair Birdsell and members of the committee. It's nice to be here. For the record, my name is Andrew Hosmer. I am representing Harvard Pilgrim Healthcare today. And though they could not be here today, they asked me to share a statement offering their perspective on this bill. I first want to assure the members of this committee and certainly the public that Harvard Pilgrim Healthcare shares in the goal of members having full, healthy, productive, and inclusive lives. That certainly is the goal of Harvard Pilgrim. Harvard Pilgrim opposes this bill right now for just a couple of reasons, but I think they're important reasons. First of all, they've indicated to me and wanted me to share with you there's not significant research and or studies that support applied behavioral analysis being an effective treatment for Down syndrome. At this point, the staff at Harvard Pilgrim has only been able to determine that there are 2 published studies that support ABA treatment for Down syndrome. Secondly, ABA providers are currently struggling to meet the needs of current autism spectrum diagnosis population, as evidenced by the extensive wait list our current provider hold, as well as an overall lack of ABA providers in the field. The addition of another population to this service would only create longer wait lists and more barriers for people to be able to access this service. And finally, the established managed care framework that has been in place for decades ensures that all treatments are evidence-based, medically necessary, and in the best interest of the member. Health insurers are able to review treatment recommendations to ensure they align with critical best practices, research, and evidence-based clinical guidelines. It's in the opinion of Harvard Pilgrim Healthcare that passing this bill would set a concerning precedent, as it would circumvent the established managed care framework. That would conclude the remarks on behalf of my client. I am happy to take questions on this, but I may not be able to answer them because it's a little out of my professional depth, but certainly more than happy to share them with my client if I can answer them. Thank you, members.
Thank you, Andrew. Senator Bradley.
Senator Hosmer,
Just Andrew today, but thank you, Senator Bradley.
you definitely drew the short straw.
Yeah.
So I just looked at the sign-up sheet. Obviously, every carrier in the state is in this room today, as is AHIP. I'm just curious from the perspective of the carriers, how many individuals are we talking about?
Thank you for the question, Senator. I think that's a very fair question to ask. I don't have that data in front of you. I don't even have it from my client in specifically, but I'm happy to follow up with that question and see if I can get you the answer.
Sure. Megan, if you want to come up here, she does have info.
Hello.
Hi. From information regarding this bill, that was the same conversation in Massachusetts. Dr. Scott Coe estimated 80 individuals, and if you compare the population, that puts us at 14 individuals here in the state of New Hampshire. Yeah.
Thank you.
Get rescued, Senator.
Senator Whitley.
Thank you, Madam Chair. I'm sorry that you're the first person to take all these questions, but Mrs. Foster provided us with a letter from Dr. Scott Coe, who is the director of the Down syndrome program from Mass General and also associate professor at Harvard Medical School. And I just wanted to provide some counter data to what your Harvard Pilgrim had referred to about the lack of studies. So this expert indicated, I'm not sure if you're aware, that ABA is the gold standard, right? And that research paper after research paper has also shown that ABA improves the acquisition of skills in children with Down syndrome while decreasing behaviors that can interfere with learning and developmental progress. So I'm not sure how this Harvard Medical School professor, how that tracks with what you presented from your client.
Thank you for the question, Senator Whitley. And I can't speak directly to the document that you have in your hands. I have not read it myself, but if you would be so kind as to share a copy of it, I'll make sure that it gets into the hands of my client very quickly. And perhaps we can have a follow. Thank you. Thank you, Senator Prentice. And perhaps have a follow-up question, a follow-up answer to you very quickly, though.
Thank you.
Yes.
Senator Bradley.
So we had a long debate last week about medical necessity on the infertility bill. As I read this, and maybe you're not the right person, Andrew, to answer this question, others could. Is there anything in this legislation, while it expands and the definition to autism spectrum disorder or adds Down syndrome, that undermines medical necessity in a diagnosis? I think we heard testimony from the parents that they had to go through the medical necessity process. Is there anything that in this that undermines that?
I'm not sure if this directly answers your question. I think that determining medical necessity is perhaps the first step, and then it's the evidence-based care that someone is either eligible for and or receives might be the second step there. So I don't think that it does, but I'm happy, once again, happy to share this with the team at Harvard Pilgrim and get you a more definite answer.
Any other questions from the committee? Seeing none.
Thank you very much, Senators.
Thank you, Andrew. That is all of the speakers we have. Is there anyone here that would like to speak that wasn't given an opportunity? With that, I will close the hearing on Senate Bill 553. We will not be executing this today. Okay, I will open the hearing on Senate Bill 354 FN and welcome Senator Prentice.
Good morning.
Senator
Our-
Ennis, you have changed.
Yes, I have no bow tie on today, and my glasses are quite different. But I am honored and to step in for Senator Ennis today in introducing Senate Bill 354, which we call the All Copays Count Act. For the record, well, first of all, good morning, Senator, Honorable Chair Birdsall and members of Senate Health and Human Services. For the record, my name is Sue Prentice, State Senator, District 5, large parts of Grafton County, Sullivan County, and one town in Merrimack, the beautiful town of New London. So again, I'm stepping in for Senator Ennis today to introduce 354. This, again, All Copays Count is an effort, a bipartisan effort with 22 senators as co-sponsors to improve affordability and reduce patient out-of-pocket expenses. I offer this legislation on behalf of Senator Ennis, but on all the 22 senators that signed on as co-sponsors, as this, I believe, will have a real impact for citizens of the Granite State. So what we know is that the need for copay assistance for prescription medication in particular is especially critical for New Hampshire citizens who have high deductible health insurance plans that require them to spend sometimes up to thousands of dollars before their insurance actually comes into play. So what copay assistance does, it is in the form of, say, a coupon or a GoFundMe effort, assistance from a church, that it's actually real money that goes to that person to help them pay for that medication that should be paid towards their copay. But what's happening here is the way it is right now is that can be taken back or not counted by the insurance carriers. And so what happens is someone goes in, thinks that they have a $500 coupon, or maybe their church gave them a $500 certificate to use to help pay for this very expensive medication, and they see after they go and they do this, they find out later that doesn't count towards their copay, so they not only have to still work to to suffice or to fill the copay over time, as well as they have to pay back. They can't use this coupon anymore. So that, say, $500 is lost to them. And that's what we're actually trying to prohibit here. The decisions around what medications, what prescriptions are, well, the decisions around prescriptions are made by physicians. They're not made in an effort to steer towards any one particular medication, as will be asserted. And it's interesting, you know, I'm in working with Senator Ennis, you can tell that he's a college professor. And I can appreciate that because he's well cited evidence here for this discussion, but just wanted to point out up front that physicians make these decisions. They are not trying to steer towards any one particular medication, but the best medication that is available for their patient. On a personal note, although it's not related to some of the different diagnoses we'll talk today, my husband, who has atrial fibrillation, had to move from one type of medication to another, and when I went in to pay for it, it was $500. And that, was a decision made by his physician and turns out to be a medically better decision than what he was on based on the fact that at the time he was a firefighter. But that was significant. So we have experienced, although we didn't have a coupon, we got one later and then had this type of experience ourselves. We understand what this means to low, middle income, and really all Granite Staters. So copay accumulators, as they're called, or maximizer programs, allow private or commercial insurance companies and pharmacy benefit managers, which I'll refer to here as PBMs, to recap significant profits while their patients living with challenging conditions like multiple sclerosis, cancer, and arthritis are forced to step aside or abandon or delay their treatment due to high out-of-pocket costs. I do understand that Mike Rollo, actually I saw him come into the room, so I don't just understand, I've spotted him, will be here today to talk about this as well. For many, this high-cost sharing requirement makes it impossible for them to afford the medications needed to treat, again, a range of chronic conditions and sometimes rare diseases that without copay assistance offered by a number of pharmaceutical manufacturers or other charitable organizations. Most of these programs primarily exist for drugs without generic alternatives. Again, the medical decisions on what is prescribed are made by the physicians. Regrettably, health insurers have worked to block patient access to this much needed assistance over the last several years. An increasing number of health plans and pharmacy benefit managers have begun implementing cost shifting strategies like accumulators and maximizers. So and I'll explain what those are, but these being instituted, the copay accumulator adjustment program prohibits a third party to provide copay assistance from counting towards that patient's deductible or out-of-pocket cost maximum, again, exposing this patient to large and unexpected costs. These can interrupt treatment regimes, and they undermine just basic patient protections and honestly put the patient in the middle, where I think we continue to do work to take the patients out of the middle and be looking out for their best interests at all times. Copay maximizers are similar to copay accumulators, but set a patient's cost sharing amount to the maximum value of the copay assistance spread through the year. So the accumulator just does it up to the point where the copay maximum is sufficed. The copay maximizer does it over the course of a year, but they both have the same effect. Copay accumulator and maximizer programs interrupt, again, the relationship between patients and their providers, while, again, increasing costs for those seeking treatment. The reason you get health insurance is to protect patients if they fall ill. The reason I have health insurance is for my, not just preventative, but if I should become ill, my ability to get treatment. Not burden low-income and middle-income populations with large out-of-pocket costs while commercial insurers can profit from this. So what Senate Bill 354 does is seek to, again, prohibit this type of action by the commercial insurers. To date, 19 states have already stopped this practice by passing, once again, bipartisan legislation that does not allow accumulator policies. Who will benefit from Senate Bill 354? Who will it impact? 309 and says 309,000, a little more than 309,000 patients in the state of New Hampshire could benefit from this. The actuarial firm Alvere and the Kaiser Family Foundation recently published a report that helps to calculate the number of lives that could be impacted by reforming these health insurance practices. Again, calling it all copays count. So this legislation would ensure more than 250,000 of New Hampshire residents would belong to a plan that must count patient assistance towards their cost-sharing limits while addressing patient affordability and, again, lowering the costs. Also, what would it impact? Secondly, or why do insurance companies do this? Unfortunately, and unfortunately here, we're talking about an opportunity as it's been presented in some of the evidence that Senator Ennis prepared, and obviously I had time to review before I came in to present on his behalf, is it allows for a practice where it stops the patient from using that, say, assistance, that coupon, so it actually then directly gets that money from them, and they don't have, again, the benefit of a coupon or a charitable organization helping to pay their copay. So health insurance companies may assert that restricting accumulators could be a cause for higher insurance premiums for everyone. But according to the Global Healthy Living Foundation, there's no statistically significant change to premiums, nor is the rate of health insurance premiums rising in the 19 states that have already passed the same patient-centered legislation. There's a powerful quote from this report that I wanted to share. Big or small, red or blue, states with laws protecting patient assistance programs have not seen health insurance premium hikes. Insurance contracts are complex, and an individual or family may not even realize that an accumulator or a maximizer program is even written into the fine print until it is too late and they are told at the pharmacy that they still owe the deductible or co-insurance for that prescription in the middle of a plan year. Despite using their PAP, their supplied funds, it's not reasonable that patients are paying more than their fair share. We encourage legislators and other advocates who develop state and federal health policy to use our tool to fight for patient protective laws nationwide. So health insurers also claim that this assistance, that there are ways, again, I mentioned earlier, to steer patients away from generic drugs, which are traditionally or typically lower cost, towards more expensive drugs. Again, this report finds that this has been proven to be largely untrue. 99.6% of copay assistance is used for branded drugs that do not have a generic alternative, and that's one of the reasons that assistance is brought forward. And only the ones who can steer a patient are the insurance companies who control the access to all drugs through formularies, prior authorization, and other administrative barriers. So again, this just goes back to the fact that the physicians, nurse practitioners, or physician's assistants are the ones making these decisions, and in many cases, generic alternatives, which are lower cost, are not available. Do we have any enough data in New Hampshire? So again, I mentioned that the American Cancer Society will be here today, and a recent American Cancer Society survey of cancer patients and their caregivers pointed out that 83% of respondents felt that the manufacturer assistance program enabled them to get medication they otherwise could not afford. A January 2023 report from that actuarial company mentioned earlier, Alvere, which I'm sure I am not pronouncing their name correctly, indicates that 83% of commercial market enrollees belong to health plans that have implemented accumulator programs, while 73% belong to plans that have implemented maximizer programs. So this is becoming a more widely used practice. In April 2023, the Pioneer Institute of Massachusetts released a new white paper that examines the impact of pharmacy benefit managers, PBMs, and copay accumulator and maximizer programs on the ability of patients living with multiple sclerosis, cancer, and arthritis to access conditions, to access the treatments for their conditions. And what did they find? So I quote, accumulator programs are a means for payers to transfer resources from manufacturers to payers without helping the patients. Again, in quote, in short, the ability of a PBM to enroll patients in these programs that keep out-of-pocket costs high is predicated on the PBM's ability to steer a patient into a specialty pharmacy. Without this steering ability, enrollment in these accumulator maximizer programs would be difficult. Therefore, state legislators that wish to limit the ability of the PBMs to keep out-of-pocket costs high can ban this requirement that the patients use the specialty PBM by these PBMs. These laws are called anti-steering laws. We're not really talking about anti-steering today. We're talking about the accumulators and the maximizers, but this was also entered into here just as an example. And lastly, I quote, it's perfectly reasonable to expect patients to bear some cost, sharing the burden, but inflicting increased out-of-pocket cost obligations so significant that the unintended consequence here is to cause the abandonment of a prescription seems as a complete inversion to the purpose of insurance, which is preventing and is treating. So policymakers who wish to protect market-based commercial insurance industry it would be helpful for us to enact this type of reform, which benefits the patients who, again, are stuck in the middle. Now, I'm happy to try to answer any questions on behalf of Senator Ennis. I think there are others in the room who are better positioned on some of the technical details, but just to sum it up, we're in a good position here to end this practice and ensure that patients get the full benefit of their copay assistance, whether they get help with it or not. Thank you.
Any questions from the committee? I have one. You may not be able to answer it, but
You have a pained look on your face. Okay, go.
HSA cards, where they're cards that we put money aside through payroll, and we get issued those, and we can use those for particular prescriptions for anything medically. Is that included in?
That's not included in here. I'm not 100% clear, so I'm not going to attempt to answer it, but I'd be happy to look it up, and there may be someone who can.
Okay.
I heard it behind me, so I think the answer is yes. Okay,
All right.
thank you.
Thank you.
Set to go? All right. All right. We've got to, yes, we got to do something about this chair situation. I complain every
Thank you.
Okay.
Thank you, Senator Birdsell, and committee members for allowing me to speak today. My name is Mary Fitzpatrick. I'm an advocate for the New England Bleeding Disorders Advocacy Coalition, which is part of New England Hemophilia Association. I live in Concord in Senator Whitley's district, and I come from a family where several members have hemophilia. I have mild hemophilia. My son has more severe hemophilia. Today, I wish to testify about accumulator adjusters, which Senator Prentice just spoke about. It's a policy added to insurance plans that allow the insurer to accept any third-party payment made on behalf of a patient and then to require the patient to still pay that bill. My family does not have coupons. We don't have nonprofits or churches paying for it. We get our copay assistance from the manufacturer of the product. I will give you a quick example. If your child or family member was suddenly diagnosed with a very serious chronic illness or was in a catastrophic accident, the bills would be very high. After insurance pays their portion, you're still left with $5,000. So your brother decides to pay that $5,000 for you. That's third-party assistance. The insurance company, if they were to ask who paid that bill, you would still be left with that $5,000 bill. Manufacturers and some nonprofits, as I said, offer copay assistance plan to patients in order to help them with the very, very high costs of clotting factor and other medications. Insurance carriers will try to convince you that by banning accumulator adjusters, as you said, it will either increase the cost of premiums or it will steer patients towards more costly medications. The bleeding disorder community does not have any other medications to use. There are no generics. The hemophilia and bleeding disorder community across the country has researched that allegation very thoroughly. And with respect to any insurance people who might be in the room, it is untrue. It is false as of today. It has not happened anywhere. Whether it would happen in the future, I do not know. And if it does happen, shame on the people that make it happen. Insurance carriers, bottom line is money. Our first experience with this practice, our story, was a few years ago. Our son received a delivery of clotting factor. He had been in a car accident. The clotting factor was $100,000. That's how expensive this medicine is. There are many people in the hemophilia bleeding disorder community that hit $1 million a year if they have severe hemophilia. Insurance paid their 80%. My son was left with a huge bill. He sent it to his provider. They sent it to the copay assistance plan from the manufacturer. They don't pay the whole thing. There's a $10,000 cap or a $12,000 cap or 15, whatever their plan is on these copay assistance. They don't keep paying endless amounts of money. They paid it. My son then submitted the bill to the copay assistance plan. They paid it, and then insurance accepted it and still billed him for the $20,000. My son has a college degree. He works at Concord Hospital, and he makes $42,000 a year. How is he going to pay a $20,000 bill? That's not going to happen. So the medications that my son and my other family members need to stay healthy are incredibly expensive. We acknowledge that. But the process of creating clotting factor and other biologics is a very complex and a very costly process, and it's the only option we have. Patients have notified our New England Hemophilia Association that they have had to delay medical treatment because they cannot afford it without the assistance plan. This could literally mean the difference between very costly disability, which would cost the insurance companies more in the long run, or death. I guess death would cost less. This practice causes untold financial and emotional stress to the patients who live through this, to their families. How are we going to pay this? And I don't think it seems fair at all. This is why I'm here today, to share our family story with each of you, and I thank you for that. The practice affects an individual's adherence to their medication and or treatment across all chronic health care conditions, not just bleeding disorders. And my husband had the same experience with his heart medication that your husband had. It went from a $100 copay to a $600 copay in 2024 for the same medication he was getting last year. That has nothing to do with this, but it's part of the whole sad story. In the states where accumulator adjusters have been banned, again, as Senator Prentice, said, there is currently no evidence that premiums have gone up. That is why very dedicated people, like the people here who are helping, like you folks, are working diligently to fight to have this practice banned. It doesn't benefit anybody except the insurance carriers. I thank you very much, all of you, for your time and for your support of Senate Bill 354. Thank you. Oh, any questions for me?
Seeing
Thank
none.
you.
Thank you. Curtis.
Good morning, members of the committee.
Morning.
My name is Curtis Barry. I'm here this morning representing the Pharmaceutical Care Management Association, which is the national trade association for the PBM industry. I've got some handouts that I'll point to. Actually, Cameron, I'll give these to you. Oh, thanks. I'll refer to these as we go along in the testimony. In Senator Prentice, I think we'll have a little bit of a dueling data, perhaps, at some point. My testimony is very brief. We're here to support the AHIP position. Ms. Kroll will testify in depth on this bill, this issue. But my comments start and end with the same statement. Drug pricing starts with the manufacturer. The fact that the cost of these drugs is high starts with the manufacturer. Please keep that in mind. I would ask you a question next. which is related to that. This bill, as introduced, what does it do to lower the cost of that drug that's coming from the manufacturer? Nothing. And in fact, it encourages them to keep the cost or the price high. This bill would encourage manufacturers to not negotiate with a PBM or a carrier for lower prices. One of the pieces of data I'd like to reference is in the sponsor's testimony that there's a vast majority of bills that this would apply, drugs that this would apply to, that are with is no generic equivalent. But those are not the only alternatives. There are other name brand drugs, alternatives, that were not referenced. In one of the documents that I handed out, this one, an independent study that shows the vast majority of drugs for which coupons apply do have a lower cost alternative. When considering this bill and deliberating, I'd ask you to keep that in mind. The other document that follows that is an illustration of how manufacturers benefit from this bill. If the coupon only applies to the deductible, and then the deductible is satisfied and the patient assistance goes away, the manufacturer still sells the higher cost drug. And who pays? The premium payers, because that additional cost is then borne by everybody else that's in the plan. Related to that, one of the things I noticed about the bill, there are 3 sections. Section 1 amends RSA 415, accident and health insurance. Section 2 amends the Health Service Corporation statute. That's RSA 420A. Section 3 amends 420B, HMO organizations. The bill doesn't seem to apply to the state employees plan. And I'm just curious why that is. Maybe there's some additional rules in the state employees plan that I'm not aware of. But if it's a good idea for patients, it should be a good idea for members of the state employees plan, the state employees and other government employees who participate in that plan, and not just the members of commercial insurers. So in some, patients will benefit, certainly, because there's a high cost of drugs. Pharma benefits because they continue to sell high-cost drugs that they set the prices for. Premium payers will have to pick up the difference. And I'll ask again, or I'll make the statement again. The price of drugs starts with the manufacturer. I'm happy to answer questions. I think Heidi knows the depth of this bill much more than I do.
Any questions from the committee?
Yep.
Senator Avard.
Thank you, Madam Chair. Thank you, Curtis, for your testimony. Just regarding not the coupons necessarily, but for those who maybe some type of nonprofit or a church. I mean, in the previous testimony, we were talking about how that somebody may donate a certain amount of money. Maybe they can be, reimbursed from, deduct that from their taxes or whatever. But I'm curious. Can you explain a little bit about how that works? I mean, if somebody donates $5,000 to lower the copay, why doesn't that go to the deductible?
Yeah, I think that's a valid question. This is the original testimony was the first I heard of outside help, if you will, other than a manufacturer-sponsored coupon that this would apply to. So I'd have to ask that question myself and get back to the committee. Thank you.
Any other questions from the committee? Seeing none?
Thank
Thank you, Curtis.
Sorry. I'll start over. Good morning and thank you, Chairwoman Birdsell and members of the Health and Human Services Committee. My name is Susanna Von Eddingen. I live in Warner, New Hampshire, And I'm also a New Hampshire state lead for the New England Bleeding Disorders Advocacy Coalition, a collaborative advocacy effort for patients with hemophilia and their caregivers. I am also the mother of a 26-year-old son with severe hemophilia A. It does not run in my family. He was adopted, so it was a learning experience and surprise. Hemophilia, and I'm just, because I don't think Mary covered it, is a bleeding disorder in which blood does not clot after trauma to the body, be it a severe cut, small cuts aren't a big deal, or an accident resulting in internal bleeding in joints or other parts of the body. My son is treated with a medication which is non-generic. In fact, it's so specific that if he were to switch to another product of the same factor, he could develop an inhibitor, which means he would not respond the way he should and develop a clot. So he is on a prophylactic dose every 2 weeks that allows him to have a healthy and productive life. He is an assistant timber framer, which means he's having big timbers and hammering and chiseling and climbing up on barns and whatever. And of course, could be subject to injuries because he's on his factor on a regular dose. Again, it's very expensive. He is able, though, to have a job, pay his taxes, have a normal life for a 26-year-old son with hemophilia. Today, I'm here to testify in support of Senate Bill 354 to prohibit health insurance policies to incorporate copay accumulator adjustment programs. I'm just going to call them CAP to save time, right, for the words. So I just wanted to give you a little example of what we went through recently. As I mentioned, he's 26 years old. He just aged out of my insurance policy, which was a good one, and was not on copay assistance at the time. Now he's working on his own. His company's very small. He does not have company-covered health insurance, so he went to the marketplace to find a policy that would cover his medical expenses, the prophylaxis, to the best way possible. He went to a state broker who was extremely experienced and helpful. However, when we asked, do these policies have caps, the broker had never heard of them and could not tell us whether or not the policies we were looking at had these practices in place. So the next step was to contact the insurance policy or the insurance agency and themselves and speak to staff. We reached out through email, we called. One company never responded to our questions about caps. The other company, and I'm going to have to read this, did send us an email, did not say, yes, we have copay assistance accumulator adjustment programs, but they did say that only amounts that the member is paying would contribute. No discounts or co-payments from the drug company will apply towards the deductible. And this is the part that got me. It's only the out-of-pocket expenses from the member, which leads me to believe that it's not just the manufacturer coupons or whatever that could provide copay assistance, but that the money has to be an out-of-pocket from the member. No third parties would be available, because then we would not be able to count those towards the deductible or the maximum out of pocket. Secondly, my son's salary, he's just starting out, is not sufficient to cover all his medical and living expenses at this time because he has a minimum monthly co-payment of $250. To us, maybe we can support that. But if he's paying his rent or electric and heating bills, and then he has a copay, I have a feeling I know what he's going to do. He is going to delay his medication, his prophylaxis, as long as possible so that he doesn't have to pay $250 on top of his other expenses every month. If he had copay assistance, it would at least cut that down to maybe a more reasonable amount, and it would go towards his deductible and out-of-pocket maximum. But at this time, the only policy we could get was the one with the cap, so it's not available to him. And I know he will delay his treatment because he's done that in the past as a young man, because it's a hassle. It's an IV infusion. You just, you're a 26-year-old boy and you really don't want to have your housemate seeing this. So he's going to put it off. And he's going to put it off because he can't afford to pay his copay every month. This bill will go a long ways towards helping young men and women or others in lower income brackets who have medical conditions, especially when there is no generic option available. And in the hemophilia community, there are no generic options available. We have to have these life-saving medications in order for our family members or ourselves, in the case of others, to survive and be productive members of this society. As a mother, I'm just so grateful this bill has been presented. And I really thank everybody's support, and I hope that it will continue to move forward and be passed. Thank you so much for your time. I appreciate it. If you have any questions, I'm happy to answer.
Thank you for your testimony. Any questions from the committee?
Just real quick.
Senator Avard.
I do have one. Just again, with the third-party assistance, does it say in the policy that it will not accept third-party assistance?
It does not say it in those words. And try reading an insurance policy. My husband has. And it's buried in there. But the agent clearly stated it's only the out-of-pocket expenses from the member. Now, if someone were to give my son a check and he paid it for his copay, who would know? But if they write it to the pharmaceutical company, and I'm not even going into being forced to use a specialty pharmacy other than the one that we've been using. I'm happy to testify on that in another case. But yeah, if they give it to my son, and is he gonna use the money? I'd rather go directly to pay the bill, right? But then the insurance company knows somebody else paid it. Thanks. Thank you.
Can I have Amy go first or Judith? Just because I'm going to go a little bit, she says.
That's okay. Good morning, members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell. I'm here today representing AHIP, and I'm looking forward to kind of clearing up, I think, some questions and happy to provide some clarity. So we actually had worked with Senator Innes on an amendment to this bill, which I have handed around. And we do appreciate his willingness to work with us and his openness to considering some important amendments that we think will make SB 354 more workable and will provide essential protections for New Hampshire's patients and premium payers. AHIP is opposed to Senate Bill 354 as introduced. And we really don't think that the bill is necessary. The reason is that this topic of when a pharmaceutical manufacturer's drug coupon should and should not be counted toward a patient's deductible has been the subject of a recent federal court case and is currently the subject of planned rulemaking at CMS. Carriers programs that track patients' use of coupons are referred to as coupon accumulator programs, as you've heard. Basically, the court vacated CMS 2021 rules on coupon accumulators and pointed back to CMS's more limited 2020 rule. CMS has announced that they have a non-enforcement policy in place right now. And while they work to write new regulations on the subject to clarify the definition of cost sharing and their provisions on coupon accumulators. So we would strongly encourage you not to pass a law that could conflict with or be preempted by forthcoming federal rules. That said, if you are nonetheless inclined to move forward with this bill in some form, we strongly encourage you to adopt the amendment that Senator Innes worked with us on. If the bill is not amended, it will undoubtedly increase premiums and cost sharing for New Hampshire citizens and employers who purchase fully insured health insurance plans. So briefly, what are copay coupons? As in other retail markets, coupons are what they sound like. In the case of pharmaceutical products, drugs, they are a marketing ploy used by pharma to gain and maintain market share for their exorbitantly priced brand name drugs. They use coupons to manipulate markets and entice patients into using more expensive drugs. A manufacturer temporarily offers a coupon in an amount that will lower the patient's cost of the brand drug to an amount that is below a lower cost alternative. They make the coupon available until the patient meets their deductible, and then they terminate the coupon, leaving the premium payers paying the exorbitant price of the brand drug, despite the fact that lower cost alternatives are available in most instances. And I'll get to that later when I talk about the amendment. What pharma should really do is lower their drug prices that they and they alone set, and they should lower them for all patients. But they refuse to do so and instead continue to maximize their profits on the backs of patients and premium payers. Manufacturers offer coupons for expensive brand name drugs, and very often for expensive brand name drugs that face competition from lower cost alternatives such as generics, biosimilars, and over-the-counter alternatives. A USC Schaefer analysis of the top drugs by spending found that 88% of brand name drugs with manufacturer coupons were medications for which lower cost generics or lower cost brand alternatives were available. As I mentioned, when pharmaceutical manufacturers offer coupons to patients, they usually offer the coupon only for a limited period of time, typically until the patient has met their deductible. A coupon can be hundreds or even thousands of dollars per month to accelerate the patient meeting their deductible. And then the manufacturer terminates the coupon, and the premium payers, namely employers, employees, and individuals here in New Hampshire, are left paying for the full cost of the exorbitantly priced brand name drugs, even though there are very often, not always, lower cost options available for the patient that would save everyone money. It is important to note that the use of coupons is prohibited by the federal government in Medicaid, Medicare, and other federal programs because coupons are deemed to be kickbacks to consumers under the federal anti-kickback statute. However, coupons are currently allowed in the commercial insurance markets. Studies have looked at the financial impacts of manufacturer coupons on healthcare costs, and it is clear that they do drive up costs for consumers and for everyone who pays premiums. For example, without Medicare's ban on coupons, taxpayers' costs would increase by an estimated $48 billion over 10 years. In the commercial market, coupons are estimated to increase costs for employers, unions, and others by $32 billion nationwide. And in Massachusetts, the use of coupons for 14 drugs in the commercial market increased costs by an estimated $45 million. Of relevance to New Hampshire, in a 2017 study on coupons, researchers compared New Hampshire to Massachusetts, which banned the use of coupons. So the researchers analyzed the impacts the coupons were having on the use of generics and drug spending. They found the following. When brand name drugs did not offer coupons, use of generic alternatives was equivalent in both New Hampshire and Massachusetts. When brand name drugs did offer coupons to patients, use of generic alternatives was 6.3% lower, resulting in increased spending estimated to reach close to $6 billion over 5 years. That estimated $6 billion was a New Hampshire-specific cost, and that was back in 2017. That cost has no doubt gotten much larger in the last 7 years. To be clear, SB 354 as introduced and in the amendment does not propose to ban the use of coupons. I want to be very clear about that. Patients who are using coupons can continue to use them under both the bill as introduced and under the amendment. What SB 354 as introduced would do is require health plans to count not only what a patient pays out of pocket on a drug toward the deductible, but to also count the value of a drug manufacturer's coupon toward the patient's deductible. And this would drive up costs in the form of higher premiums, but also give pharma further unfettered free rein to raise the astronomical prices on their drugs even more. So I'd like to give you an example of what we're talking about here with coupons. I'm an employee of Gallagher, Callahan, and Gartrell. If we are out of pens and I happen to go down to Staples to buy pens, and when I walk into the door at Staples, I happen to see a coupon for Bic pens. I wasn't planning on buying Bic pens. I was just going to buy the generic pens. But I see there's a coupon for Bic. A box of Bic would have cost me $25, but with the coupon, it's only going to cost me $15. lower than the other alternative that was the generic. So I buy that, I save myself $10. When I go back to my employer and I fill out my expense report, I am filling it out for $15. I'm not filling it out for $25. I don't count the coupon. And so that's what we're talking about here. So people are allowed to use the coupon. They should not be allowed to count it toward their deductible. And the amendment, I'll get into the amendment in a bit in terms of when there are generics or other lower cost alternatives available and when there aren't. As you've heard, some carriers attempt to track the use of coupons using so-called coupon accumulators so that only the patient's out-of-pocket cost on a drug is counted toward their deductible. I will say, I just wanted, because it was a question that came up, if my mother or my uncle or somebody like that were to help me pay, that's not what we're talking about here. My uncle or my mother, it doesn't matter to them which drug I'm using. They just, obviously they want to help me cover my medication. So that's not what this bill, at least in our opinion, is talking about. It's when coupons are involved because manufacturers are trying to corner market share and drive consumers toward higher cost drugs when lower costs are available. That's what we're concerned about. There's an allegation that when carriers don't count the amount of the coupon towards the patient's deductible, that carriers are somehow pocketing the coupon. That assertion is entirely untrue. At no point do health insurers keep the coupon. When a coupon is used, the value of the coupon goes from the manufacturer who issues the coupon to the pharmacy as the alternative to the consumer. They're married with the consumer payment, and then back to the manufacturer as the alternative part of the payment for the drug. So how would SB 354, as introduced, drive up premiums? The bill means the farmer would use the coupons to put the patients on an accelerated path toward meeting their deductible. As I mentioned, if somebody has like a $6,000 deductible, coupon can be $1,000 or $2,000. Somebody is going to accelerate through meeting their deductible. Once their deductible is met, the lion's share of the exorbitant costs of the drug would then be picked up by other premium payers. And of course, next year when the insurance premiums are set, they will be higher to account for the cost shifting. So this cost shifting, in our opinion, is unfair to premium payers who are stuck paying for the extremely high cost drugs when lower cost alternatives exist. The shifting is an added expense to the healthcare system, and it's entirely a result of pharma setting astronomical prices and trying to drive up market share through the use of coupons. I also wanted to mention that SB 354 would only target New Hampshire's fully insured individual and employer-sponsored health plans. The bill would not apply to the self-funded market or to Medicaid or Medicare, where coupons are considered kickbacks and they are prohibited. As you know, we are concerned about mandates on the fully insured market continuing to drive more and more folks out of that into the out of the fully insured market and into the self-funded market where these mandates don't apply. And as you've heard me say in other hearings, currently the fully insured individual and employer markets make up only about 28% of the total market in New Hampshire. And of course, as there was discussion earlier, this mandate would not apply to high deductible health plans due to IRS rules. The IRS has said that people with high deductible health plans cannot count coupons toward their deductible or will invalidate the high deductible health plan and create a tax liability for the patient. So as I mentioned, we worked with Senator Innes on amendments to SB 354, and we very much appreciate his willingness to work with us. And we believe the amendments, and I think, from our discussions with him, he believed as well, would add important protections and cost-containing measures for New Hampshire patients and premium payers as well. So first, the amendment will only allow coupons to count toward a patient's deductible when there is not a lower cost alternative drug available, namely a covered generic equivalent, a covered interchangeable biosimilar, or an over-the-counter equivalent, or a covered drug in the same therapeutic class that may be preferred under the health plan's formulary. So under our amendment, if you are on a high-cost drug and there is no generic or no lower cost alternative, you would be allowed to count the coupon toward the deductible. If there are lower cost alternatives available, you would not. We think that's fair. Second, for the drug manufacturers that offer the coupons, it will require them to provide some consumer protections to New Hampshire patients and premium payers. Manufacturers would be required to offer the coupon for the full year of the consumer's insurance plan, not the bait and switch where they only offer the coupon for a few months. They would have to notify the consumer if the coupon will be discontinued in the following year, so the consumers can make informed choices about their long-term medications. And they would have to offer the assistance regardless of the type of health plan to the extent allowed under federal law. And they would have to offer the coupon prior to or upon purchase of the purchase of the drug, not after the fact. Third, the amendment places some common sense transparency requirements on the drug manufacturers to notify the insurance companies of basic information when coupons are used by health plan enrollees, namely the name of the enrollee, the name of the drug, the amount of the coupon, the terms of the coupon. And finally, the amendment sets the effective date, excuse me, to January 1st of 2025, which is typical with mandates so that the new requirements would sync up with the start of the insurance policy. So in sum, coupons are a marketing ploy used by pharma to gain and maintain market share for their exorbitantly priced drugs. There are plenty of studies out there that back this up. Pharma and pharma alone is the one setting the drug prices at astronomical levels. What they really should do is lower their prices for everyone. You shouldn't need a coupon to afford your drug. Unfortunately, they continue to do just the opposite, raising their prices at alarming rates and to outrageous and unsustainable levels. We see the press every day about this. We do not believe that SB 354 is necessary or appropriate given the planned rulemaking at the federal level. However, if this committee is so inclined to move forward with SB 354, it is absolutely critical, in our opinion, to adopt the amendment that we worked on with Senator Innes. This amendment will help put downward pressure on insurance premiums, and it will provide important patient and premium protections, payer protections in the fully insured markets. With that, I'd be happy to try to answer any questions.
Thank you, Heidi. Senator Prentice.
Thank you. Good morning, Heidi. Oh, so maybe I'm just not 100% clear on this, but why, setting aside the costs of medications and the high cost medications, why is it that a patient can't use a coupon or another form of assistance towards their copay? Is it just that you not believe, but you have, you have evidence? I think it was referred to earlier as maybe dueling evidence that it will drive the cost of premiums up. I mean, what is the pushback on allowing people who need the assistance to use it to pay for their medications? Is it just that the drugs are too high in their cost?
So to be clear, nothing in either the bill as introduced or the amendment would prohibit somebody from using the coupon or any other assistance. So that's not the issue here. The issue is whether you get to count a coupon. And we're not talking about, from our perspective, we're not talking about if your uncle or your mother or your local church or whoever helps you pay for your drug. We're not talking about that. We're talking about coupons. Our concern with counting coupons toward the deductible is the whole reason that pharma is using coupons when there are competitive, when there's competition, when there are lower cost alternatives. They are using it to drive market share to them. And so they use a coupon just like any other coupon you would use. They use the coupon to lower the cost of their highly priced drug, bring the price below a lower cost alternative until you have met your deductible. And then they withdraw the coupon and everybody's stuck paying for the higher cost drug when there are lower costs available. When you sign up for an insurance plan, what your deductible is very clear. And we think it's, fair that everybody should meet their deductible. And you shouldn't use, in the example I gave, with the, buying pens, when a coupon is used, it's a marketing ploy. It's not what anybody has actually paid out of pocket. We want what people have actually paid out of pocket to count toward the deductible.
Thank you, Senator Bradley. And not just a separate question. Has Senator Innes signed off on this amendment?
We worked on it with him, and we thought he was bringing it in today. So I don't. Yeah.
Okay. Thank you.
Further questions, Senator Whitley, Senator Prentice? All right, I have a couple. All right, just looking at the amendment, I get that there would be a supposition on the part of the insurers that if there is a generic or lower cost alternative, that if the enrollee was being driven toward the high cost brand name, that the policy should not apply to that. I think that's actually reasonable. But
Right,
what
and
I don't think is reasonable for the insurers to say, and look, I get there's a lot of finger pointing. I've sat in this room for years, and you've finger pointed at the drug companies, they've finger pointed at you. There are reasons in the United States of America that drug prices are through the roof, R&D costs are outrageous, the FDA approval process takes forever. None of the other industrialized world, they all have price controls on drugs, so American consumers pay for it. And oh, by the way, there's inflation of everything, and medical costs are there too. So the finger pointing probably isn't productive. Okay, so having said that, you're being made whole. It doesn't matter how you're being made whole. If the copay is being paid for, it doesn't matter how it is being paid for. If it's $1,000 copay, why does it matter? Now, I get that if it applies to a, you know, if it's buying market share for higher cost drugs, that I understand, but the rest of it, I don't.
Yeah, I think to answer your question, Senator, let's just take a drug that costs $1,000 and there's a coupon for $700 and the other remainder is $300. The cost of the product in that case is $300. It's not it's not $1,000. I mean, that coupon is just as I mentioned in my testimony, the coupon comes from the manufacturer, goes to the pharmacy, and it goes back to the manufacturer. So, you know, the coupon is a way for the manufacturer to lower the cost of the drug at that point in time for a couple of months until, and then once the patient has met their deductible, the coupon is withdrawn.
Thanks, Cam. Seems to me you're double dipping. You're taking the drug company money plus the enrollee's money toward the deductible. I mean, that just, I understand if that enrollee is being driven to a higher price drug when there is a generic available or an equivalent available for a lower cost. But I think we've heard testimony that for some of these biologics and cancer drugs and a whole range of things, there just is no other, because of the 17-year, patent protection for pharmaceuticals.
So just
there
to be,
isn't any.
yeah. So just to be clear, in the amendment that we worked on with Senator Innes, if there is no lower cost alternative, the coupon, not only would the patient be able to use the coupon, but they would be able to count it toward the deductible. That's our give. There is, I respect, with all due respect, there is no double dipping. In the example I gave where I went to Staples and I bought a box of pens, they were going to cost $25, but there's a coupon there and I only spent $15 for the box of pens. As an employer, going back with that expense report, I paid $15 for the box of pens.
I guess we see it differently.
Okay.
The carriers are getting their money. All right. So putting that aside, if there's a reasonable compromise on generics in the amendment and the effective date seems reasonable, and the transparency piece, I think, which starts on page 4 of the amendment, please explain to me what the other sections of the bill actually do, the amendment, the health service corporations, fairness and cost calculations, okay?
Yeah. So because this language is being put in multiple sections of insurance statute, there's just duplication. So that's why there's 3 sections here to the bill, but they are very much repetitive. So I don't know if that answers your question. Yeah, I mean, the first part, for example, just looking on page 1, the first part is about lower cost alternatives. The B, Roman 2B is about the IRS, the high deductible health plans. We don't want to be leaving anybody with, I mean, this is a carve out. If we don't have this language, and we have it in a few of our other mandates as well here in New Hampshire, if we don't have this, we're going to be leaving patients who have high deductible health plans with a tax liability. I don't think we want to be doing that. This is the third part, again, is what I mentioned, just some what we think is fair to patients who are going to be using the coupons. You know, the coupon shall be available for the full plan year. If it's going to be discontinued, patients should know about that, so they're making informed choices. And you know, that should be extended to any type of plans as allowed. You know, we do have the federal prohibitions. And then the transparency piece is simply requiring, you know, the drug manufacturers to disclose to the carriers the name of the enrollee, the prescription drug for which the coupon is attached, the amount of the coupon, and any terms that go with the coupon. And then we've got the date. So that's pretty much it.
Okay, any other questions? Seeing none, thank you very much.
Thank you.
Sabrina, representing Anthem.
Thank you, Senator Bradley and members of the committee. I'm Sabrina Dunlap. I'm Director of Government Relations for Anthem. Thank you for the opportunity to speak today. We do oppose the bill as written. I think we would likely be supportive of the amendment that was discussed. I won't repeat everything Heidi said. I agree with the general concepts that she raised. I do think the bigger picture is important here, though, and considering the bigger implication of the coupon copay programs, and think about why they exist in the first place, which is in fact the high cost of drugs. The price is set by the drug company. I will try not to get into finger pointing, Senator Bradley. But I do think, you know, it's notable that the federal government considers these an illegal kickback. And there are many studies I could point to. A recent Harvard study that I sent to Senator Innes talking about when you use copay coupon programs, the costs go up, and patients do get locked into high cost brand name drugs. And I wasn't going to comment on this, but I feel compelled to, since I have a deep lived experience myself in the world of rare disease and biologics and high cost drugs. And I heard a comment earlier about patients being put in the middle. And I actually think it's the copay coupon programs that put the patient in the middle. One of my kids has a very rare chronic disease with no cure. And she was put on a biologic early on. And at the time, I did not know much about insurance and was not very savvy in the healthcare world. And I think out of goodwill, we were just told, well, sign up. This drug company has a copay program or a coupon program. And so without even considering what my insurance was covering or not, I signed up for the program with the drug company. And I think we paid like $100 a month with that program. But the biologic stopped working. It failed after about 2 months. And I recall that we found out we'd have to go on a higher cost biologic, and there was no program for that biologic. And I remember at the time feeling sort of a sense of panic. You know, with those coupon programs, I understand the appeal, but I don't think it's as simple as saying they work great, they're the solution to the high cost of drugs in this country. And I just offer that perspective that do I think that that was helpful at the time? Not really. My insurance covered the higher cost biologic and it was all okay. But as a patient or as a parent experiencing that, I don't think it was helpful. And I don't think that these coupon programs should be encouraged. I understand that's not entirely what this bill is about. But I do just want to point out that in my scenario, my insurance company was not the problem. The high cost of the drugs was the problem. So I think that is all I will say on that. And thank you for the opportunity to testify. And I'm happy to take any questions.
And Vice Chair, hey. That's right. Thank you. I forgot. Earlier, there was some testimony regarding third party, and I was out of the room when Heidi was talking. But as far as the restriction of if somebody wants to donate, whether it's a church or something to that effect, and apply it towards the copay, can you talk a little bit about that? Is that why wouldn't anybody bother if it doesn't apply to the copay if that's the scenario? But
Thank you, Senator. I want to make sure I heard everything. So are you talking about an example where like a family member wants to pay toward?
or a church or a nonprofit of some sort, you know, they have this extra money they'd like to donate to help assist in this particular type of thing. But when they say they donate $5,000 or $10,000, it doesn't apply to the copay. And I mean, that's the test. I believe that's the testimony I heard. So if you can clarify that a little.
Yeah, I'm happy to, thank you. I'm happy to follow up on that. I'm not sure I quite understand how the logistics would work. I think it seems more likely someone might have a bill from a provider or a hospital that they needed assistance paying. And I don't think it matters necessarily if, you know, a family member was trying to help you. I can't imagine making a distinction as the carrier. But I will definitely look into that because I'm actually not entirely sure.
Seeing none. Thank you very much.
Thank you.
Mike?
Mr. Chairman, members of the committee, for the record, my name is Mike Rollo. I'm the Director of Government Relations for the American Cancer Society Cancer Action Network here in New Hampshire, and we are appearing in support of Senate Bill 354. And I also have the proud opportunity to be the leader of a coalition of 19 other public health and chronic disease organizations that are also in support of this legislation.
Did you happen to see the amendment too?
Oh, I have, Senator, and I'm going to talk to you about that in just a moment. I am, and I have a different take on Senator Innes's involvement as to the drafting and support of the amendment.
Mike, can I interrupt for a moment?
Of course.
My understanding is Senator Innes had not approved this amendment, even
Yes,
though his
sir.
name is on it. Just
Yes, sir.
For everybody in the room to be clear on that.
That would be my understanding as well, Mr. President. That would be my understanding as well. But as I said, I have the great opportunity to lead a coalition of a vast cohort of chronic conditions that are supporting this, from multiple sclerosis, lupus, hemophilia. You've heard from a few folks that are living this experience right now, their families, HIV, AIDS, patients rising. This runs the gamut of chronic diseases. So I don't want anyone to think this is just cancer, which we all know is a very expensive disease to treat and to manage in some cases. But as I said, we are very happy to be here in support. Most of what I was actually going to talk to you about, Senator Prentice covered for Senator Innes. So I don't want to be duplicative, but I do want to cover a couple of things. And Senator Bradley actually got to the crux of what I wanted to talk about, and that is the fact that Senator Innes is not not in support of of the amendment that does bear his name. He and I have exchanged emails about this amendment, and I'll tell you why the American Cancer Society is very much concerned about this amendment that's floating around. It exempts, there's a line, I don't have it in front of me. I didn't bring it because I didn't believe that Senator Ennis really wanted to talk about it, but it's been introduced now in conversation. It exempts the same class of covered drugs, exempts the same drugs in the same class. And those drugs may be in the same therapeutic class, but have very different methods of action. Those cancer drugs, I mean. So that makes the bill rather meaningless for folks that have cancer. It makes the entire bill meaningless. It also strips out the section, I believe, if it's the same amendment that Senator Ennis shared with me, on essential health benefit protections. There are caps under the EHBs that are under the Affordable Care Act that are in our current law. It would strip out that, or rather, that are in this proposed law. Sorry. In this bill, it would strip that section out. So you're also taking away protections for patients. And to be clear, I'm here representing cancer patients. I'm not an apologist for the pharmaceutical industry. I'm not an apologist for the healthcare industry. I'm here representing cancer patients. And it's hard enough when you receive a diagnosis, whether it's cancer, MS, whatever, any of the groups that I've mentioned or that are listed in some of the handouts that we've already given you. You want to just manage or treat those conditions. You don't want to be dealing with how you're going to be managing to pay your copay. And to be clear, these folks have insurance. These folks aren't looking for handouts. And so I don't typically read my testimony, but I want to just read one part of it. To be clear, SB 354 is not a coverage mandate and does not require that insurance companies cover any particular drug or class of drugs. Nothing in this legislation prevents insurers from using their existing utilization management tools, such as step therapy or prior authorization. We are only addressing copay assistance that is being used by patients for drugs that their insurance company has already made the decision to cover, and their doctor has determined they need. Patients still have plenty of skin in the game when it comes to making and paying for their healthcare decisions, as they are still paying their insurance premiums, and patients with chronic illnesses don't have the luxury of foregoing certain healthcare treatments and services until they can more easily afford them. I think I'll leave it with that. And as for the analogy of staples, you know what the difference between copay assistance and the Staples analogy is? At the end of the year, Staples isn't going to ask the person that brought up that analogy for the difference back so that she can then go back in and continue to purchase items at Staples. But those that are being asked to make up the difference of the copay assistance are being asked to do that. That's what the difference between these folks that are getting copay assistance from other companies and in the Staples analogy. That's the difference. So I will be happy to answer any questions that I can, but I think that we've probably gone a lot over the 20 minutes that was allotted for this legislation. So,
questions from the committee?
Thank you. Not so much a question, but I guess I would ask the advocates, yourself taking the lead, and you remember how we worked together on the oral chemo drugs years ago, and the insurers, met the challenge. Thank you very much.
Yeah, they did.
So I'd ask you to, do the same thing. I have to say, based on the testimony I've heard, I'm not sure I have a problem if generics are available. So start there and see if you can bring us back a compromise.
And I appreciate that, Senator. I think from my organization's perspective, the overwhelming majority of the treatments do not have a generic equivalent. I think that's the problem.
that is a problem, and I don't think it should preclude the use of, these accumulators to help patients in that
Yeah.
situation.
I appreciate that. And we're always willing to compromise if it means better legislation. I think the problem is the so-called compromise that's being floated around right now is not so much a compromise. It's just undercutting the legislation in general. So, but thank you for that.
Further questions? Seeing none? Thank you very much, Mike.
Thank you, sir.
Who wants to follow up? Seeing none, we're going to close the hearing. All right, so we're going to hear from the prime sponsor on what bill? That is 355. And we're going to hear from Senator Ennis. Welcome, Senator.
Hi there. Happy to pinch hit. Good morning, Chairman Avard in this case, and members of the committee. My name is Grant Bossy, Deputy Chief of Staff for the New Hampshire Senate, and I'm here to introduce Senate Bill 355 on behalf of Senator Dan Ennis, the bill's prime sponsor. He is still across the street. Cytomegalovirus, or CMV, is known as the stealth virus. You may have never heard of it, but it's actually quite common. In fact, many of us may be infected with CMV and never know it. That's because for most healthy people, CMV has no symptoms. Most of us will never develop symptoms. If you've got a compromised immune system, however, CMV can be very serious. In fact, it's the most common cause of hearing loss in children. It can also lead to blindness, developmental disabilities, cerebral palsy, and epilepsy. This leaves pregnant women and their babies most at risk. 1 in 200 babies will be born with CMV. The baby usually doesn't show any obvious symptoms at birth, but they can develop serious health problems months or even years after birth. Knowing that a newborn has CMV can make a world of difference should they develop these problems. They can be given antiviral medications, have more frequent hearing tests, more frequent vision tests. SB 355 would add CMV to the newborn screening panel required under RSA 132-10A, warning parents to be wary of CMV symptoms. Additionally, the bill would require an amniocentesis to confirm a congenital CMV infection should the infant show certain symptoms during an ultrasound, or if the mother is diagnosed with CMV during pregnancy, which is a way it can be transmitted. We know the risks of CMV to our newest granite staters. Knowing an infection is present can give parents and their doctors the advanced warning they need to provide timely, effective treatment. Senator Ennis asked to share a letter from his daughter-in-law, Heather Ennis, about their experience with undiagnosed CMV. I would defer questions to those with people with more medical knowledge than I possess, but if you do have a question for Senator Ennis, I can make sure to get you an answer. Thank you for your consideration of Senate Bill 355.
Thank you, Grant. Other questions? Senator Whitley?
Thank you, Mr. Chair, and thanks for taking my question. You know, of course, I fully support a broad array of maternal health and newborn screenings. My biggest concern with this bill is the fact that it requires an amniocentesis, which I'm not sure if you're aware is a very invasive prenatal test. And requiring amniocentesis is particularly troubling to me because it takes away the decision-making authority from the individual, the woman, who would be required to have a very invasive procedure, potentially medically necessary. And also, you know, this conversation that should be happening, not in the State House, but with a woman and her doctor. So why in any other case do we require an invasive test like this apart? Why are we taking this decision away from a woman and her medical provider and putting it in the State House?
I can't speak for Senator Ennis. I'll get that question to him. I have had some discussions with him, and his largest concern is that pregnant mothers know the risks and have the options available to them. So I'm sure he'd be able to discuss that particular issue with you in greater depth.
Follow up? Yep. Is there any other situation where we require an amniocentesis?
I can look into that for you.
And lastly,
Follow up, yes.
to me, I'm curious whether you agree, this is reminiscent of a requirement that was made by this legislature, probably, I think it was in 2021 budget cycle, requiring a medically necessary invasive ultrasound. This is very reminiscent of the same requirement, this invasion of a woman's right to privacy and bodily autonomy. Would you agree?
I have no opinion on such matters, Senator.
Thank you.
Oh. Oh. No further questions? All right. Thank you, Grant. Appreciate
you.
that. Would it be better if we just put the word may? Yep.
No
Hey,
worries.
Ben, how you doing? Welcome.
Thanks, Senator. Good morning. Thank you, members of the committee. For the record, my name's Ben Bradley. I'm the Vice President of State Government Relations for the New Hampshire Hospital Association. We represent all of the state's community hospitals, including 15 birthing hospitals, as well as all specialty hospitals throughout New Hampshire. The Hospital Association is appreciative of the sponsor's effort to bring attention to this really important issue, and our member hospitals remain committed to participating in the newborn screening program. However, I would like to share a few concerns for the committee's consideration. RSA 132 colon 10A established the newborn screening program and requirements for determining which disorders should be screened at birth. As part of the program requirements, the Newborn Screening Advisory Committee was established. The Department of Health and Human Services, Division of Public Health Services, manages the program and convenes an advisory committee on which the Hospital Association has a seat and appoints a designee from a hospital to participate. The advisory committee is responsible for studying conditions included in the screening panel. This is the process established in law, and we ask that the legislature allow for that process to be followed for the consideration of adding CMV or any other condition to the screening panel. Historically, when legislation was proposed to add specific conditions to newborn screening, the legislature determined it would be most appropriate for the Newborn Screening Advisory Committee to review the current science, the medical and ethical evidence, and for adding the condition to the screening panel. I'd like to emphasize that we're not opposed to adding this condition to the list, but that it be brought up with the Newborn Screening Advisory Committee for their consideration and deliberation using the process that is laid out in current law, instead of legislating specific newborn conditions. In addition to these process concerns, the Hospital Association is opposed to Section 1B, beginning on page 2, line 8, which requires a doctor, as Senator Whitley pointed out, to perform an amnio if a pregnant patient is diagnosed with CMV during pregnancy. We're concerned this may force testing and invasive procedures on pregnant patients when it may not be in line with the wishes of the patient. We would consider this provision as legislating medicine, which we cannot support. Finally, the statute changes proposed in the bill on page 2, line 15, add to our hospital's financial responsibility to cover the cost of performing amnio procedures. Although the statute affords hospitals the ability to seek reimbursement from commercial insurance, Medicaid, or other payers for this test, if a payer does not agree to fully pay or only partially reimburses, or if a patient is uninsured, hospitals would have to assume the cost of the mandate to perform amnio procedures. Thank you for the opportunity to provide my comments. I'm happy to answer your questions.
Any questions from the committee? Seeing none. Thank you.
Good morning. My name is Lisa Royce. For the record, I am
administrator in the Division of Public Health Services, overseeing the Bureau of Family Health and Nutrition, which includes lots of our maternal and child health programs. We're here to provide information for Senate Bill 355, and I have Courtney Keene here, who's our administrator for the newborn screening programs.
Good morning. So my name is Courtney Keene. I'm the administrator for the newborn hearing screening program and the newborn screening program, also known as the Blood Spot. I would like to thank Senator Innes for bringing attention and awareness of CMV through this legislation. I want to start with saying this is a two-part bill: infant screening and maternal screening. In New Hampshire, the newborn screening program, also known as the Blood Spot, is responsible for ensuring that all infants born in New Hampshire are screened for 37 heritable disorders, which if left untreated can lead to disability or death. There is an option for families to opt out. CMV, the most common infectious birth defect in the United States, with 1 in about 200 infants becoming infected, or approximately 20,000 each year. Of those infants born with CMV, only 1 in 5 will have long-term health problems, and they range from slight to severe. Currently, there is a process in place for adding additional disorders to the newborn screening panel. In New Hampshire, the Advisory Committee, a legislatively formed committee under RSA 132-10A, is responsible for determining whether a disorder is added. The committee is comprised of specialists, including pediatricians, genetic counselors, New Hampshire Hospital Association, midwives, special medical services, to name a few. The disorders are added to the panel, the disorders that are added to the panel are chosen based off of evidence that supports the benefit of screening, ability to screen for, the cost, and the effectiveness of treatment. Screening for infants for CMV should be done within the first 21 days of life, and the preferred method is urine, saliva, and then blood. At present, the CDC does not recommend that doctors routinely test pregnant women for CMV infection. This is because the laboratory tests cannot predict which developing babies will become infected with CMV or have long-term health problems. It is up to the provider and the patient to determine if further testing is needed. Thank you for the opportunity to provide testimony today. I'd be happy to answer any questions that you might have.
Any questions from the committee?
No.
Are you sure?
My little squirrel's going, but I can ask later, I think.
Seeing none, thank you.
Thank you.
Good morning. Good morning, Chairman Birdsell and members of the committee. My name is Carolyn Drury. I am here representing the New Hampshire Academy of Audiology. Director Keene just talked a little bit about some of the hearing loss. I'm here to speak specifically to that subject. It is one of the conditions that a child with CMV can have. The concern, basically from studies done by the CDC, is that CMV is not well known. Only 1 in 10 women of childbearing age have ever even heard of it, but it can be very devastating to their baby. One of the leading causes of acquired hearing loss in young children, infants and young children, as opposed to being genetic. Of those infants who are born with CMV, 4 out of 5 will appear healthy and show no signs. So we do need to catch that quickly. Sensory neural hearing loss is not medically treatable. So once it's there, and it is progressive, so it worsens over time, and that's very unpredictable. We don't know. Some can show a very rapid drop in hearing from a mild to profound loss in 2 years. Some take a much slower course and develop slowly, really up into their adolescent years. We have to keep monitoring and staying on top of that through that whole process. A lot of youngsters show, those who have it, show delayed onset. So we have to be screening them regularly, audiologically, to kind of see if we can catch it early. It is very important. 90% of speech and language is acquired normally by age 5. So those first few years, the infant, toddler, and preschool years are very critical to getting ahead of this, and so that that youngster does not come into the schools with a very large delay in either speech or very difficult hearing. So we want to just try to catch them. We need to catch them early. Obviously, most youngsters learn to speak within that early period. They're kind of wired for it. So any treatment that we can start early is where you get your best bang for the buck. It is your best value. Let's see. Also, both the American Academy of Audiology and American Speech Language Hearing Association recommend newborn screening for CMV. I'm just going to say the old adage applies: an ounce of prevention is worth a pound of cure. In closing, if there are any other issues, we are willing to serve as a support for the committee if other questions should come up. Thank you for your time and consideration.
Thank you, Carolyn. Any questions from the committee? Being none, thank you. That is the last speaker on Senate Bill 355. Oh. Mine. That was the last speaker on Senate Bill 355. Is there anyone here that would like to speak on it that was not given the opportunity? With that, I will close the hearing. And when Cam is ready, we'll open the hearing on 496.
Good morning, Madam Chair, members of the committee. My name is Shannon Chandley, and I serve the people of District 11, Amherst, Merrimack, Milford, and Wilton. I come before you today to introduce SB 496, and this bill would establish a program within the Department of Health and Human Services to monitor and respond to the harmful impacts of climate events or on mental and physical health. So we know that New Hampshire is experiencing extreme weather events as well as other changes in our environment. We know that we currently have seen longer growing seasons, later explosion of fall foliage. We have had intense heat waves, intense rain, snow, and storm conditions, flooding. There are wildfires not terribly far from us that affect our air quality. And most of us recognize these changes, but don't always think about the health impact that they have. And they can have harmful effects on our health. And that includes things like tick-borne and mosquito-borne illnesses, babesiosis, Lyme disease, West Nile virus. There are heat-related illnesses and deaths due to intense heat waves. There are also pulmonary and cardiac health impacts from some of these events. And as well as, one we don't necessarily think as often about are the mental health impact. Now, we know that some agencies in our state do monitor and track the weather events. What this bill would do would be to require that the Department of Health and Human Services actually reestablish a program that they did have to track the health impact and help us to become more resilient, adaptive, and innovative in how to address the problems going forward. I heard something recently that I thought was very interesting, and that is when people talk about changes in our weather or our environment, they tend to think of its impact on animals and bugs and forests, plants, even maybe on farms, but they don't think about the effect on human beings. And of course, it's all interrelated. One cannot be affected without another effect taking place. So we know that the effect on humans is real, and we want to consider ways to address it. I ask you to please look favorably on this bill. HB 490, old habits die hard. SB 496 will help New Hampshire collect New Hampshire data to find New Hampshire solutions. I'm happy to take any questions that you may have, but I would also point out that there are a number of people with greater subject matter expertise than I who are prepared to speak. So thank you very much.
Thank you, Senator. Any questions? Senator Whitley.
Thank you, Madam Chair, and thanks for taking my question. I think it's very timely that you raised this issue. I wasn't sure if you were familiar with a new article from Harvard Public Health, actually. Harvard Public Health indicating that there's some new evidence that's revealing that the climate crisis is affecting neurological and mental well-being more than previously understood, particularly for children.
Thank you very much. I think that's an incredibly important point. I'm glad you raise it, and I believe that there are folks here who can speak further to that issue. It's very important.
Seeing none.
Thank you.
Thank you,
And
Senator.
if I might just add, the one thing I didn't say is I'm really happy to work with anybody who wants to refine this going forward if there's any further questions. But thank you.
Thank you. Michelle Roberger. And Leanne. Yep. Welcome.
Can you hear me okay with the mask on? I have a little bit of a cough, so. Okay. Sure. Thank you, members of the committee. For the record, my name is Michelle Roberge, and I'm the administrator for the Bureau of Public Health Protection within the New Hampshire Department of Health and Human Services, Division of Public Health Services. And with me today is Leanne Atwell, who is the administrator for the Environmental Public Health Tracking section within the Division of Public Health Services. As introduced, SB 496 directs the department to establish a climate and health protection program in response to health threats associated with extreme weather. The department is not taking a position on this bill, but would like to provide the following information and also note that the proposed legislation does not provide an appropriation to the department to establish this program. As written, the proposed legislation directs the department to collect and analyze data and to plan and implement strategies to prevent and respond to current and emerging impacts on human health associated with extreme weather. It also directs the department to develop and provide educational resources for New Hampshire residents on associated health threats to assure that New Hampshire residents are alerted to any impending health impacts associated with extreme weather. In 2013, the department established a climate and health program with federal funding from the Centers for Disease Control and Prevention. The department received about $200,000 per year for a grant for the grant periods. One was 4 years and the second was 5 years. The CDC unfortunately discontinued this funding for New Hampshire in 2022. And so the department has not had state or federal funding to continue to support this program since. Some of the work that the department's climate and health program focused on included collaborating with peers through an advisory group, training workforce on topics including health impacts associated with extreme weather, heat injury, emergency preparedness, and tick-safe practices. Funding for projects that focused on building community resilience through the development of 5 regional adaptation plans using CDC's framework. And we also developed and provided key messaging on health impacts of extreme weather and how better to adapt or prevent these types of health impacts. In order to complete the work outlined in the proposed legislation, the department would need to have a climate and health prevention program manager position and an appropriation to continue implementation of evidence-based strategies focused on building community level resilience against the health impacts of extreme weather and emerging environmental threats. As stated in the department's fiscal note, an increase in state expenditures starting in state fiscal year 2025 is anticipated to account for this program in the range of about $157,000 for 2025 to about $176,000 in 2027. If an appropriation were provided, the department envisions that this position could work closely with partner agencies such as the New Hampshire Department of Environmental Services, the Department of Safety, Homeland Security, Emergency Management, and other partner agencies such as the Federal Environmental Protection Agency, CDC, and others. I would like to note that the department last year worked pretty closely with DES, the Department of Environmental Services Air Resources Division, along with New Hampshire Homeland Security Emergency Management to deal with, if you remember, we had those Canadian wildfires, so the air quality, certainly in states are surrounding us. Thankfully, New Hampshire didn't experience those really poor air quality days because we had a low pressure system kind of hanging over New Hampshire. But if it weren't for that, we would have experienced very poor air quality. And so it prompted us to really look at how we can better prepare for emergencies such as this. So we worked collaboratively with those agencies to develop a response protocol so we could be prepared in future years should a situation happen like that. So certainly thank you for the opportunity to provide this testimony. We'd be certainly willing to work with the bill sponsor on any revisions to this bill. Happy to answer any questions.
Thank you. Senator Prentice.
Thank you, Senator Burzel, and thank you for coming before us today. So just, I'm looking at the fiscal notes, so I've got this straight.
Yep.
You had a position, or you have, or had a position that was CDC funded.
Correct.
And so in order to do this, you'll now need an appropriation for this position.
Yes.
Okay.
Unfortunately, yeah, we don't have that position anymore.
And follow up. So when you talk about public health support service agencies, and this is kind of a question or a statement mixed in together. Have you thought about the role of community health workers as well as the public health networks, which have a home in your department? So if you haven't thought about them, I just think they'd be great partners in doing this kind of work where this has a real strong public health focus.
Yes, absolutely. We were working directly with communities. We had some small grants that we were providing to help build community resilience in communities. But certainly all of that would be, those are great ideas, and certainly we can continue to expand on the program if we have some resources to do so.
Great, thank you.
Yep.
I do have a question. So the program that the CDC ended, stopped funding, how long was it running and what types of things did they get accomplished?
Yeah, so we had 2 grant periods, and I can certainly speak for the latter part of it. I came into DHHS in 2018. And so there was a grant period from 2016 to about 2022 when the funding, unfortunately, was a 5-year competitive grant in New Hampshire, unfortunately, and several other New England states were not awarded. We applied for a new grant cycle. Unfortunately, we weren't awarded that. At the time, there was a lot of wildfires and flooding happening out west and down south. And as I said, this is a competitive grant federal process. So unfortunately, New Hampshire and other New England states were not awarded. The type of work that we focused on was, obviously, we created an advisory group, so collaborating with peers through this advisory group, we established we focused on training workforce on topics such as heat injury or emergency preparedness, tick safe practices. So working with educators and such on tick safe practices. I think you're going to actually hear from Matt Cahaleen, who used to be the program manager for this position at the department. So I'm sure he'll be able to share a little bit more. We also funded some mini grants to communities, again, to help build community resilience, build response plans, regional adaptation plans to help, better prepare communities really for any threat, whether it's a flooding event, a heat event. Building that community resilience throughout New Hampshire is important to be able to respond effectively and quickly to help communities adapt to situations. And also we partnered, we work closely with Department of Environmental Services, who does a lot of work in this area as well. So we partner well with them as well. So.
One last question. Is there, excuse me, do you know if there's an open period where the grants are going to be, they're going to push out the grants again that we can apply?
They would have re-upped in 2021, I believe, is the time. So and I think they're 5-year periods. So it is a period of time before the next renewal cycle will start.
Thank you. Any other questions? See none. Thank you.
Okay, thank you.
Matthew Cahaleen? Cahaleen? Cahaleen. Ah.
This is the perfect segment. So, good morning, Senator Burzell and members of the committee. My name is Matthew Cahaleen, and I'm a public health professional, and I was the manager of the prior climate and health program that operated in DHHS from actually around 2013 to 2022. I support the bill and have a few comments on how the proposed legislation might be best implemented. I'm speaking as a citizen today representing myself. My background, I've worked in public health for over about 3 decades, focusing on environmental hazards, measuring health impacts, and taking action to reduce the risks. Over the last 10 years, I've focused on weather, climate, public health impacts, and published several peer-reviewed research articles. I'm also an instructor at Antioch University. Today, I have good news, bad news about a changing environment, some of the knowledge gaps that still exist. The good news is that on a national level and a state level, our citizens are well adapted to some of the extremes in heat and precipitation. As the climate warms, we've been able to reduce heat-related deaths significantly over the last 50 years, cutting the risk of death in half, especially for our cities. In addition, we have been able to improve air quality and reduce premature deaths by over 100,000 people per year. These are improvements you rarely hear in the media or from advocacy groups. I believe we need to teach our citizens their history and youth about the past successes if they have hope and insights, and needed to take on the challenges of the future. Bad news, and I won't cover a lot of this because I think other people are going to do more of it, is the climate is rapidly warming. It's causing disruption, unbalancing our ecosystems, and threatening some of our health. We can and will adapt to these changes in our state, yet mitigating the global causes will require significant effort, free market innovation, and international cooperation. And those are very different from what the successes I just mentioned, a different kind of challenge. I expect you would like to know more about if a health impact, more than just if a health impact could be related to weather or climate in some way, but you'd like to know how much, when, and where the impacts are due to weather versus climate. That's what we tried to do within the Division of Public Health when we ran this program, to come up with good evidence that people could make decisions on. Here's a short list of the accomplishments from our prior program. They include, we built a team with expertise and dedication to public service. We collaborated with state agencies and universities to collect that data. We identified climate hazards, estimated disease burdens, and took action at the local level. We launched 5 community interventions in the Upper Valley, the Seacoast, the Lakes region, Nashua, and the Monadnock region to reduce health impacts from heat, storms, floods, and ticks, and try to build that resilience that will help people adapt to these changes that are coming in any way, whatever that hazard might be. We published research on the disease burdens and those interventions, and we educated especially our outdoor workers and emergency preparedness professionals on how climate conditions might affect their planning and response efforts. And we try to be very collaborative across state agencies. Here's a list of the knowledge gaps that any future program could pursue, including improve the ability to collect data on hazards like flood and pollen, much of that is missing, improve ability to collect data on health impacts in the primary care settings and outside of emergency departments in our vital statistics and death data, develop methods to estimate the proportion of health impacts due to weather versus climate change, develop interventions to prevent health impacts and increase resilience, and interpret the dozens of climate and health studies that are published each year to prioritize the most relevant information for decision makers. In closing, I believe the state needs a climate and health program that will provide both the legislative and executive branches with clear, concise, evidence-based information that will allow you to make sound decisions on policy, resources, and public health. It's also important to recognize that if the state doesn't take the lead on climate and health issues, we know that someone else will. And it may not share the same values or dedication to public service or to the information that is really important. So thank you for the opportunity to speak, and I'm happy to take any questions or comments.
Any questions from the committee? Seeing none, thank you. Bob Dunn. Welcome.
Thank you, Madam Chair, members of the committee. It's good to be back in Senate HHS, my first time this year. I'm Bob Dunn, the Director of Public Policy for the Roman Catholic Diocese of Manchester, and I'm here today on behalf of Bishop Peter Labashi to respectfully register our support for SB 496. The reason that I'm here is, as you may know, Pope Francis has put a lot of effort into trying to elevate the environment in the minds of people both inside the church and outside the church as one of the moral imperatives of our time. Back in 2015, he issued an encyclical letter called Laudato Si, in which he called the climate a common good. And he named climate change a global problem with grave implications that represents one of the principal challenges facing humanity in our day. And one of the reasons that he thinks that this is such an important thing is because of its impact on the poor and the voiceless. He said in that letter that the way that we think about the environment is related to the way that we think about human beings as well. He said in the letter, when we fail to acknowledge as part of reality the worth of a poor person, a human embryo, a person with disabilities, to offer just a few examples, it becomes difficult to hear the cry of nature itself. Everything is connected. So if Pope Francis was sitting in the room when Senator Chandley used the word interrelated, he would have been nodding vigorously. Now, obviously, 496 doesn't touch on any of these great global challenges, but it does deal with how those global challenges matter to us here on the ground in New Hampshire, and how these global challenges impact our own fellow New Hampshire residents. And so we think that reestablishing this program is something that will advance the common good and will highlight the importance of climate change as an issue here in the state and everywhere. So with that, I'll close my testimony and simply ask that you vote to pass on Senate Bill 496. Thank you.
Thank you, Bob. Any questions from the committee? Seeing none, thank you.
Thank you.
Paul Friedrich.
have some copies of my statement and give some references if the committee is interested. Thank you, Senator Birdsell and the committee for having us here today. My name is Paul Friedrichs. I'm a retired family doctor from Exeter, and I'm here to explain my support of Senate Bill 496. I was aware of the Pope's concern about climate and health, and I'm glad that the Pope is on our side as well. I spent my entire career working for a nonprofit community health center in Rockingham County, where I made the health needs of my community my calling. During these past almost 40 years, I've seen these health needs evolve in concert with environmental changes that have been hard to ignore. These include, for me personally, the Squamscott River in front of my house no longer freezes enough to allow skating or ice fishermen out on it. I now get deer tick bites in the winter, including this past Christmas and February last year. I've had to tell my patients to start taking their allergy medicine in mid-March instead of mid-April because of the earlier pollen. And I've had to, when I built our home in New Hampshire, I never expected to need air conditioning with its large porch and great cross ventilation, but I've had to install air conditioners every summer to deal with increasing sweltering days. If we look at the numbers here in New Hampshire, here are some examples. Between 1979 and 2020, Concord saw an increase in 7 more days with a heat index above 90 degrees, and which is a heat and humidity measure that, when compared to 75 degrees, increased emergency room visits in New Hampshire by 7.5% and heat-related deaths by 5%. 82% of New Hampshire's population lives in counties now averaging more than 9 extreme heat days per year and face projected increases of up to 16 degrees Fahrenheit compared to historic norms within the next 75 years. And we just don't have the infrastructure built yet to cope with that heat. Since detailed records began in 1868, 6 of the top 7 hottest years in Concord have been since 2005. 2023 being the warmest, which broke the record set in 2016, which broke the record set in 2010. Each 1 degree increase in air temperature allows for a 4% increase in water retention, driving increases in heavy downpours, a 71% increase in recent decades, leading to increased flooding and nutrient runoff that, together with increasingly earlier ice out dates on our lakes, has led to steadily increasing cyanobacter toxin warnings by the State Health Department. Our frost-free season has increased by 34 days between 1970 and 2020, making for a longer allergy season that impacts our asthma and allergy patients. Our mosquito season has increased by 2 weeks, increasing the risks of Triple E and West Nile virus infections. And tick-borne illnesses have proliferated. Lyme, in my years in New Hampshire, up thousands-fold. And now we've documented that babesiosis, which is an intracellular parasite not unlike malaria, has a documented increase of 372% in New Hampshire in the past decade, while Maine was documented up 1,400%, and Vermont, these infections increased 1,600%. So these trends in public health have been identified, are increasing, should be monitored, and our residents deserve to be educated in disease prevention. The World Health Organization has identified these and other climate changes as the greatest health threat of the 21st century, and the New England Journal of Medicine, along with more than 230 other healthcare journals, have called for emergency action. So I feel we should include a program for climate and health in our state health department for the well-being of our citizens. Thank you for listening to me today. I'd be happy to take any questions.
Any questions for Dr. Fredericks? Seeing none.
Thank you.
Thank you. Cynthia Nichols.
Good morning.
Morning.
I also have some copies of my testimony tonight. So my name is Cynthia Nichols. I'm a RN care manager, and I'm here with the Healthcare Workers for Climate Action, as well as speaking to my experience just as an RN care manager. Thank you for the opportunity to speak today. As an RN care manager, I help people move back to home from the hospital. Some of these folks have things like COPD or heart failure, and they're going to need oxygen 24/7, or they might need breathing treatments. Some people have kidney failure, and they might need to get out of their house 3 times a week to get to dialysis. Other folks have mental health issues, or they might have various levels of dementia where they actually need caregivers to keep them safe at home. And then some people are, challenged for ambulation. Just they need to be in a walker or use a walker or be in a wheelchair. I always tell these folks when they go home that they need to let their fire department know that they're coming home and let them know what their needs are. That's because with increased extreme weather events, they're pretty vulnerable. They'll need to help during those events. They'll need help evacuating. They'll need somebody to make sure that they're being taken care of. And if there's a power outage, a lot of folks are going to be in trouble because their medical equipment won't function. So these vulnerable community members are our neighbors, our grandparents, our older, our children even, and we need to be taking care of them. As these extreme weather events increase in frequency, we need to develop plans for taking care of them in those events. DHHS is actually the right department to assess those, how to coordinate and how to facilitate plans to help these vulnerable community members. I actually had a chance to work on 2 projects with DHHS through that CDC funding that was previously mentioned. I worked with on a project that Matt Cahillaine's office supported. In the Monadnock region, we brought together community members to talk about what they saw as potential challenges and what services they needed. And we wanted them to identify the most important things to address. One of the things they identified was that emergency management directors in the 33 towns in the Monadnock region didn't have a chance to communicate with each other very often, and it would be really great to coordinate their resources and their information, and then in the event of in an extreme event, be able to communicate easily. So based on that, I had an opportunity to do workshops with with a bunch of emergency management directors. And it was a great meeting. It was a very robust discussion. People enjoyed getting to know each other, enjoyed having a chance to talk about what resources they had or didn't have, and how to coordinate activities going forward. So that creates efficiency in the system. It was there I heard a story about one gentleman who works at Monadnock Community Hospital, and during the 2008 ice storm, people were out of power for 3 weeks. He found a bunch of community members that needed to do their respiratory treatments every day and didn't have a way to do it. So he created like a respiratory room at the firehouse. It's very innovative and very New Hampshire to figure things out, but that's ad hoc. And we really need to be coordinating our activities and not have to do it at the last minute in the back room. So what they identified at that meeting was that they wanted to continue to work together. They created a communication network, and they identified what resources they need to figure out they needed and what they had, what they didn't have. So that was a very productive meeting. So those are just 2 examples of things that were funded by that program through the CDC, and I hope that we will continue to do projects like that to increase our resiliency. I think that DHHS has the skill and the expertise to understand the public health impacts of climate change and the public health needs that are going to be coming up with this new and changing weather system going forward. That's why I'm supporting 496, and I appreciate your time. Do you have any questions?
Any questions from the committee? Seeing none. Thank you,
Thank you.
Cynthia. Robert Fader? Right now, we have 2 more speakers. Next speaker is going to be Robert Dewey, and our last speaker will be John Gage. So just for prep. Welcome.
Thank you. Honorable members of the Health and Human Services Committee. My name is Robert Fader. I've been a resident of Hollis and a practicing psychiatrist in New Hampshire for over 40 years. I'm a past president of the New Hampshire Psychiatric Society, and I've served for over 20 years as the New Hampshire representative to the American Psychiatric Association. I speak to you today to urge you to support Senate Bill 496. This bill would create a much-needed climate and health program within the Department of Health and Human Services. You are hearing from other speakers today about the multiple health needs for this bill. I wish to point out specifically the need for this bill from a mental health standpoint. Climate events such as excessive heat, storms, flooding, and wildfires have significant impacts on the mental health of those who experience them. Multiple studies have shown that the incidences of major depression, post-traumatic stress disorder, generalized anxiety disorders, substance use disorders, and suicides all increase by 2 to 3 times their baseline levels in the survivors of significant climate events. Losing your house, your possessions, or even loved ones in a flood, a hurricane, a tornado, or a wildfire is one of the most stressful human experiences imaginable. Also, as sea levels rise, people living along the coast may have to eventually abandon their homes and their property. Rising temperatures alone present a risk to those already suffering from mental health conditions, as the severity of mental health disorders is known to increase with increasing temperatures. The state of New Hampshire, along with much of the country, is currently struggling to meet the mental health needs of its citizens. Patients in need of care wait for days in emergency rooms for inpatient beds to open up, or for weeks on waiting lists for outpatient treatment. Can you imagine what this is going to be like if the demand increases 2 to 3 times beyond what it is already? New Hampshire needs to start preparing for this potential scenario. We need a clear understanding of the resources available and what will need to be added. We need to work on programs to increase the resiliency of populations at risk, so they will be better able to withstand climate events and be less needy of the limited mental health resources that will be available. The word health in SB 496 includes mental health. This bill will allow New Hampshire to begin and follow through with the process of knowing what it needs to do to be ready for the dramatic increase in mental health needs, which we will see if climate change continues to follow the path it is currently taking. I urge you to support Senate Bill 496. Thank you.
Thank you so much for your testimony. Any questions from the committee? Seeing none. Next up, Robert Dewey. And John Gage, you're after Robert.
Good morning, Senator Birdsall and members of the committee. My name is Robert Dewey. I am a retired cardiologist from Catholic Medical Center, where I worked for 35 years, and a resident of Bedford, New Hampshire. I'm also a member of the New Hampshire Healthcare Workers for Climate Action, a local nonprofit group here in this state. And as a practicing cardiologist for over 30 years, I repeatedly observed how my patients would become decompensated. My patients with heart and lung disease would become unstable when exposed to even low to moderate levels of air pollutants, especially ozone and particulate matter. Particulate matter comes primarily from burning fossil fuels, tailpipe exhaust, and wildfires. And of course, wildfires are rapidly increasing as the climate warms. Particulate matter, or PM 2.5, is concerning because these particles are so small they can be inhaled deeply into the lungs. Once there, they can actually cross the capillary membrane and get into your circulatory system. Health problems from particulate matter include worsening chronic lung disease, asthma in children and adults, increased risk of dementia, heart attack, and strokes. And recently, particulate matter is felt to be a cause for behavioral problems in children. And although Matt Cahaly correctly said particulate matter is really a success story because it has dropped considerably, but still 40% of Americans live in areas of unhealthy particulates. To bring it back to New Hampshire, a report from the New Hampshire Department of Environmental Services from March of 2018 stated that particulate matter causes 1,300 premature deaths in New Hampshire annually, over 500,000 acute respiratory illnesses, 67,000 lost work days, all at a cost of $3.7 billion annually to the New Hampshire economy, which in a sense is a surcharge for our continued use of fossil fuels. Another health problem we are experiencing in New Hampshire is the rapid increase in tick-borne diseases, as stated by Paul Friedrichs. And I won't go into that because he stated that pretty clearly, but these are diseases, Lyme, anaplasmosis, and babesiosis, that we really were not seeing at all in New Hampshire as recent as 40 years ago. And these ticks it's just a result of the warming climate and shorter winters. So these are just two of the many health problems from climate change. Climate change is increasing, and these health impacts are only going to get worse. So we clearly need to study these so we can respond in the most efficient manner. And that is why I support Senate Bill 496. This bill will allow us to collect and analyze data on current and emerging impacts due to the health climate, due to the changing climate. And with this information, we will be able to develop strategies to help improve the health of the citizens of New Hampshire. So I urge you to support this bill. Thank you.
Thank you very much. John? Welcome.
Thank you, Senator Birdsell, Chairwoman, and committee members. I'm John Gage. I've lived in Windham, New Hampshire for 30 years. Thank you for hearing my testimony. I hope you will support this bill. I'm speaking as a citizen, but I'm the volunteer state coordinator with Citizens Climate Lobby, a national organization that's nonpartisan and grassroots, founded to create the political will to enable Congress to pass effective and fair climate legislation. Our main policy is carbon fee and dividend, which addresses the market failure, the failure of the market to cost pollution in the price of fossil fuels. That's related to the funding of this bill. When we address climate pollution, we also address the associated particulate and other pollutants from fossil fuels. Reducing our fossil fuel use makes people healthier. The bill my group advocates for is carbon fee and dividend, and the bill that is there, the Energy Innovation Act, according to a Columbia study, will reduce SOx and mercury pollution from electricity generation by 95% in the first 10 years. So getting cleaner electricity and more energy efficiency directly improves the health of people. What we're living with right now are the costs of the pollution from fossil fuels in many ways. And you're struggling a little while ago with, well, how do we pay to address the health implications at the state level because of the impacts of this pollution? There was a bill last year in the House, HCR 5, which called on the state attorney general to join other states in pursuing damages funding from the fossil fuel industry to cover some of these costs from its pollution. The fossil fuel industry has known about its pollution for 40 years and fought amazingly successfully to prevent addressing the pollution problem. How has this affected me personally? Well, I don't work anymore. I left my job at Oracle Corporation 5 years ago because I read science reports from the United States Global Research Program, the Intergovernmental Panel on Climate Change, and I have a degree in biology and a strong background in science. I worked in a lab for 2 years. And what I learned through science and how sure it is led me to lose sleep and not be able to focus at work. I found a group that had a good bipartisan solution. that taught me all the things I could do to help Congress pass this. And it came to a point where I was no longer able to focus on work. I kept thinking, oh, I should write a letter to the editor. I should go testify for hearing. I should do, and so personally, I see the mental health implications of climate pollution. They cost me directly. They're costing the state. I hope the state will take this big problem of climate seriously. And this bill is one particular positive step forward, both to acknowledge the problem and to think about how we want to pay for these things, because this shouldn't be taxpayer money, but it has to be, because the external costs of the pollution from fossil fuels have mounted up to the trillions of dollars. We will never be able to recover that money from the profiting industry that is misleading society and manipulating politics to delay addressing its problem. But we need to be talking about this now. I hope you support this bill. Thank you so much.
Thank you, John. Any questions from the committee? Seeing none. That was the last speaker on Senate Bill 496. Is there anyone here that hasn't spoken that would like to on 496? With that, I will close the hearing. And Jeb had a noon, so we're not going to be able to exact any. I think what I'm going to do is start making a list of bills that I'd like to try and exact, and maybe next week, either before or after, get 4 or 5 of them out at least. All right. I'll let you know in advance if you have any amendments. Make sure we all get it so that we can review them before next week. All right. That is it for Health and Human Services. Have a great week.